You have the power to stop this virus.
By being fully vaccinated, you are not only protecting yourself, but also those who are unable to get the vaccine,
such as children under the age of 12.
Our greatest tool to beat COVID-19 and its variants is in your hands, Philadelphia.
And we're counting on you to use it.
Juntos hay que proteger nuestra comunidad y vacunarnos hoy.
Together we will beat COVID-19.
Good morning, and welcome to the Philadelphia Inquirer's third annual Telling Your Health Story Conference. I'm Charlotte Sutton, the Inquirer's health editor, and I'm so pleased that you're spending your day with us. After 20 months of a worldwide pandemic, the ongoing racial reckoning, global economic upheaval, and so much more, we all have plenty of stories to tell. Today is about a very specific kind of storytelling, though. Stories that elevate experience, enhance empathy, and even affect change, sometimes massive change. You'll hear from nurses, doctors, and activists who not only have worked tirelessly throughout the pandemic, but who are using their experiences and, yes, their storytelling skills to help address the circumstances and the inequities that made COVID so devastating. And you'll get hands-on practice in honing your own skills of observation and writing from leaders in the field of narrative medicine. So I hope you're ready to work. Also note, the entire conference is being taped. So if you want to rewatch something or if you had to miss something, it will always be open to you on Inquirer.com. I'd like to thank our sponsors, Independence Blue Cross and the Robert Wood Johnson Foundation, whose generosity has made it possible for us to offer this day to all of you entirely free of charge. And the support of the Lenfest Institute for Journalism and the leadership of the Philadelphia Inquirer have been invaluable. So let's dive right in with what has become a tradition at Telling Your Health Story. And that's warming up for the day with some actual storytelling on paper or whatever it is that you like to write on. In fact, I'd suggest writing on your computer or tablet because we're going to want to see what you've written. And if you're brave and willing, we'll be asking you to share some of what you've written in the comments field so that our speakers can share them with everyone. So please join me in welcoming our first presenters. Dr. Naomi Rosenberg is an emergency medicine physician, an assistant professor of emergency medicine at Temple University. She also is a member of the medical response unit that has been working at Philadelphia International Airport to help thousands of Afghan refugees find new homes in the United States in these recent months. Her presentation partner, Michael Vitez, directs the narrative medicine program at Temple. And before that, he was a reporter at the Philadelphia Inquirer, where he won the Pulitzer Prize for explanatory journalism for a series of stories about people approaching the ends of their lives. Together, Mike and Naomi have recently launched a 12-credit graduate certificate of narrative medicine program at Temple that's open to students and practitioners in the health professions and also in related fields. You can find details on their site, along with some really wonderful storytelling. So with that, Naomi and Mike, welcome to the stage.
Hello, everyone. It's great to be with you here this morning. You know, having spent 30 years at the Inquirer and 5 years at Temple now with the narrative medicine program, I love being part of this event. It's like the, you know, collision of my two worlds. I'm a storyteller. I believe the best way to reach someone and to stir someone is by telling a story. Our brains are wired for story. That's how we see the world. I tell the medical student, well, at Temple, I've tried to bring this love of stories and this belief in the power of stories to a busy medical school and hospital. And I tell the medical students, if you listen, really listen to your patients, you're much more likely to love your patient, to build trust, to find meaning and satisfaction yourself, and to get a better outcome. I truly believe that. And students and doctors and nurses at Temple see and do and experience extraordinary things, often brutally hard things, sometimes inspiring and even sublime things. And they need an opportunity to reflect, to process, to discover. So we try to build opportunities for reflection and storytelling into a busy academic medical center. And it's been a great joy and second career for me to do this. And one of the primary ways we do it is through a narrative medicine workshop. And one of my great joys and privileges of working at Temple is working with Naomi. She's a fabulous doctor, writer, editor, and teacher. And we complement each other. We have, and it's just been so fun. And I think she's going to lead you through this workshop. And so I'm going to we'll tag team this, but I'm going to hand off to Naomi to take over.
Thanks, Mike. And thanks, Charlotte, for the introduction. And welcome everyone to what has proven to be a wonderful day here with the Inquirer at the Telling Your Health Story conference. As Mike and Charlotte mentioned, it's my pleasure to be here for the third year in a row, and in this format as circumstances dictate. We want to talk a little bit today about how we find our stories. They live within us. We know that they're there, but sometimes it can be hard to find the words to get them out or the time to get them out. And so we want to spend a little bit of time kicking off today to let everyone who's participating tell a little part of their story. And I'm joining you from Temple University Hospital and the Lewis Katz School of Medicine here at Temple, where I spend a lot of my time seeing patients in our emergency department. And like Mike said, the rest of my time teaching. And in my own country, Abraham Verghese said that the language of science, there are some things the language of science fails to communicate. And I believe that too. I think that there are some things that science can't quite teach us about what happens in the interaction between a doctor and a patient, or a nurse and a patient, or a chaplain. But literature can teach us about all of that, and has for a very long time. And since you'll be hearing from Rita Sharon later today, I have to say it is under the teaching of the narrative medicine department at Columbia, where I have learned many things about how to do this. And I wanted us to go through today a piece of literature that they introduced to me several years ago, and has been part of their teaching as a way to honor them and their program. So we'll go ahead and we'll start with a reading. We'll look at literature to teach us something we might need to learn today. And I'll go ahead. When we're in person, we have participants read the readings out loud, but in this format, I'm going to go ahead and read it, and we'll look for places where the writing has energy. So as you read through it along with me, look for lines that stick out to you or words that stick out to you, and we'll have a chance to talk about it after. This is Kindness by Naomi Shihab. Before you know what kindness really is, you must lose things. Feel the future dissolve in a moment, like salt in a weakened broth. What you held in your hand, what you counted and carefully saved, all this must go, so you know how desolate the landscape can be between the regions of kindness. How you ride and ride, thinking the bus will never stop. The passengers eating maize and chicken will stare out the window forever. Before you learn the tender gravity of kindness, you must travel where the Indian in a white poncho lies dead by the side of the road. You must see how this could be you, how he too was someone who journeyed through the night with plans and the simple breath that kept him alive. Before you know kindness as the deepest thing inside, you must know sorrow as the other deepest thing. You must wake up with sorrow. You must speak to it till your voice catches the thread of all sorrows and you see the size of the cloth. Then it is only kindness that makes sense anymore. Only kindness that ties your shoes and sends you out into the day to gaze at bread. Only kindness that raises its head from the crowd of the world to say, "It is I you have been looking for," and then goes with you everywhere, like a shadow or a friend. So let's hear from you. Let's start a discussion in this virtual format about this poem, and let's hear from you. Let's start with some lines that stick out to you in this poem. You can enter your thoughts in the comment section.
Can I say that one of the wonderful things about these workshops is we take the students and the residents right off the hospital floors and their busy lives and give them poems like this to read, and it totally changes their orientation and their focus. And we really ask them, like we are with you, just to dive in and think about it. It's wonderful what they come up with, as I'm sure it will be with what you come up with.
So we hear that one thing that stuck out to a reader was the landscape between the regions of kindness. And if you care to share a line and share why that line sticks out to you, or what you notice about the poem. Someone else mentions the idea of what kindness really is. The notion of what kindness really is. Someone else writes the line, "It sends you out into the day."
I had a resident the other day, an anesthesia resident. I did this poem with him, and he said it made him think of a Dolly Parton song, and that took me by surprise. And he said everyone wants happiness, but nobody wants rain. Then he quoted the line about sometimes you need a little rain before, I can't remember exactly what he said, before you get to the sunshine. And he sort of, I'm butchering the Dolly Parton song, but it's always amazing where people's minds go and what they relate to when they read these.
So we hear here about the contrast between kindness and sorrow.
Right.
We could ask ourselves, what is the writer doing by putting kindness up against sorrow? Is she suggesting that kindness is the opposite of sorrow? Would you expect that something else would be considered the opposite of sorrow? What's the relation in this poem of kindness and sorrow?
I kind of think, Naomi, that it's you need one before the other. And, as she says, before you know kindness is the deepest thing inside, you must know sorrow is the other deepest thing. And it made me wonder, and a lot of the students I've worked with ask, what did the author go through? Did she experience some horrible sorrow? Is this her sort of journey and come out on the other side?
Right. So she's writing about two things that are side by side and different, comparing them in a way. Someone writes about the references to food and to emotion that feel particularly striking to them. They write how one makes no sense without the other. And I wonder if we find that to be true, if other people relate to that idea. It's written about quite a bit, sung about, as Mike just mentioned, that having one somehow makes the other deeper or more different. Someone mentions this line, "Only kindness that ties your shoes."
Right.
I think about that, what the writer means by that, how she ties kindness to these very simple acts and these very physical acts that you might not think of as acts of kindness. Someone writes, "Shoe tying is a symbol of caring," and I think that's exactly what she means. Tying your own shoes to get ready for the day, or perhaps tying someone else's shoes who can't tie their own.
I wonder, Naomi, what we talk about is, the bus, being on the bus and how desolate the landscape can be and how you ride and ride and ride. And I guess that's, what the doctors and residents do in a way is it's so busy, they ride and they ride and they ride and they think the bus will never stop. They're just it's such a busy life and can be such a hard and challenging life, especially during the pandemic now, 20 months long. And I know that when we do this workshop with the students and the residents, they seize on that.
Yeah, absolutely. So someone writes about this line in the second part where you must see how this could be you. And this is where we start tying literature to our own experience. So the second part, before you learn the tender gravity of kindness, you must travel where the Indian in a white poncho lies dead by the side of the road. You must see how this could be you, how he too was someone who journeyed through the night with plans and the simple breath that kept him alive. And as we talk to patients and doctors and nurses and other people who may or may not consider themselves readers and writers, we look to these universal experiences that literature brings us about death, about pain, about suffering, and this part that's written so beautifully about the idea of connecting ourselves to people whose experiences might be different than ours, about people who may have been going along one way and plans changed in an instant, as she says at the beginning. Before you know what kindness really is, you must lose things, feel the future dissolve in a moment, like salt in a weakened broth. And I think a lot of us might now, I've been able to relate since working in the emergency department, watching people whose futures dissolve in a moment, or whose ideas of the future have dissolved in a moment. And I think we might now have a more collective experience of that, as we all look to the future in a different way in February of 2020 than we might now. Someone else writes, the author has involved all of the senses, and that they agreed with the idea of the simple acts. It's very relatable to a reader. So this poem, written several years ago, still remains relatable, and that's what one of the other things we talk about a lot, about where in literature these universal experiences that we might learn about. Someone else writes about the line tender gravity. They write, this shows the necessary two sides of kindness, how you have to know the heavy and serious, and how it must also be infinitely gentle. I like that phrase, infinitely gentle. I think there is something infinitely gentle about this poem and about this idea. Someone new writes, without understanding suffering, one cannot sympathize or especially empathize. We need empathy in order to connect with one another. It is this connection and empathy which urges us to react kindly to those in need. This is something we think a lot about, is what part of, do we need to have shared experience with people to have compassion and empathy? Or are there some pieces of experience that, like I mentioned, are universal, and that seeing others in pain, emotional or physical pain, can touch off something in us, whether we've shared the exact experience or not? Someone else writes, this seems to be a poem about empathy. What are the connections between empathy and kindness? These are the kinds of things that we like to discuss. Right. Someone mentions the line, it is only kindness that makes sense anymore. I wonder who among us feels that way, that the only thing that makes sense is kindness anymore. That's a rather revolutionary idea, that would be the only thing that makes sense. Although this writer talks about how after sorrow, kindness, it is only kindness that makes sense anymore.
It's a beautiful thought. It is.
Yeah. Someone else in the comments goes back to the beginning, like salt in a weakened broth, and says you can actually taste how kindness can change a situation. So this use of the metaphor of the future dissolving like salt in broth. Some of the other references to food and to taste and to the senses. And then this reader tying it to an idea later in the poem that kindness can change a situation. You can actually taste it.
Love that. That's great.
In answering my question, someone writes, kindness is essential to real empathy. Sympathy is more removed. In empathy, you're getting much more deeply into another's experience. So this idea of connection and how close we might be to one another, whether our experiences are shared or not. Someone else, in answering my question about kindness, writes that kindness is based on love. So as we read through the poem, we ask ourselves, why might this relate? I know many of us joining us today relate to a health story from the point of view of a patient, some from the point of view of a healthcare provider or hospital or medical staff. But we could ask ourselves, why does this relate? And we've already gotten into some of it, but why might this relate to us? Mike shared a story about working with the residents recently in the hospital. I think those of us, again, who work and train doctors and residents and students know that this idea of empathy and where to find it, what brings it about, is quite close at hand, and also how we might express it, not only in our words, but in these small acts that people mention. Certainly our nurses know deeply about that, about the physical acts that bring kindness and empathy to patients without words. Someone else writes, with empathy, there is no judgment, it is acceptance. Beautiful. And some of these ideas that we try to get at, thinking about not only our own health stories, but as we're providers of healthcare, what is it that we want to bring with us to our patients at the bedside or in the office, and how might we do that? And we turn to the poets and painters and singers and writers to teach us about these ideas that come up again and again and again in our work. So we'll hear a few more thoughts about the poem in a minute, but as we do, I'd like to ask everyone to get their pencils or pens or computers ready. We're going to go ahead and do a little bit of writing, as we always do for anyone who's joined us before. We ground ourselves in the room by reading a piece of literature, and then we get pen to paper or fingers to keyboard, so we can do a little bit of writing and exploration of our own.
You know, writing is an act of discovery, everybody, as you know, and the blank page is a beautiful creative outlet. And, you know, I love this portion of these workshops, and I'm always amazed what can come out in a brief period of writing.
So we're going to get going. As some of you know, in narrative medicine, we don't ask you to just write. I might say, write me your story, and some of you would say, okay, and others of you might feel terrified. So instead of just asking you to tell us your story, we're going to respond to the piece of writing we just read together. And so we're going to ask you to write us about either a kindness or a sorrow. So at the top of your page, a kindness or a sorrow. And we'll give everyone 8 minutes to write. We'll write about a kindness or a sorrow, and we'll see you back in a few minutes. Okay, so welcome back, everyone. Hope you had a nice few minutes putting pen to paper. And as we keep talking, I want to invite anyone who wants to submit their writing sample. I won't identify you by name, but we'd love to read a few of them out loud. So anyone who'd be willing, submit your writing sample in the comment section at the bottom of the page, and that will make its way towards us, and we can go ahead and read some of those out loud. So not all of us consider ourselves writers, like I mentioned, and we use this. And if I asked you, and I want to acknowledge that some of us have had quite a difficult time for any number of reasons in the recent year or years, or maybe even in the recent day or two. And I know that if you asked me as I walked out of a patient's room to tell you the story of what just happened, it would be much different than if you asked me sitting quietly in my office a few weeks later. I was just writing up some of our experiences at the airport welcoming evacuees from Afghanistan and giving that a little bit of time to settle. So sometimes as we read and as we give ourselves time to write, different things come out as we move through. I'm going to start reading some of the things that have come through so we can hear what people have contributed this time around. I'll read the first one, just a few lines. His face is contorted with distrust and anger, but I breathe out kindness, smiling into his frown, singing into his deep red with my yellow blue. Slowly, he begins to breathe me in, and we turn lavender together.
Thank you. I'll read one. I lead a writing group for cancer survivors. In our 7 years together, there have been more acts of kindness than I can even remember, let alone count. People have offered bread, coffee, a hand, a hug, and once, and we hope again. People have laughed until they almost choked and cried, then thanked the reader and the listeners for their silent but so expressive love. One moment of kindness, two women bold together, both bald, two women, sorry, I blew that, two women, both bald, sat together.
Thank you for contributing that. And good writers always say that great writing gives specific details. And so when you share with us that you're working with cancer survivors, and then you mentioned two women, both bald, so we sat together, we can be right there in the room with you. Thank you. I'll share another one. This is a continuance from the first one. So let's see. One had a scarf tied elegantly around her head. The other wore a faded lilac bandana, tied so loosely it was slipping off her head. The woman in the scarf took the bandana gently and showed the other how to fit it, how to tie, and how to believe that it really hid the bald scalp that embarrassed her so. The sun shone on their wrapped heads. No one said anything. Thank you. That brings us right back to these moments of kindness that don't require words. I think something special happens when we put them into words, but the acts themselves don't require it. Continuing, I'd like to think that the other patients in the room had felt that kind of wise, experienced touch on their bald heads, their scars, their numb fingers. We all need those hands so full of grace. Mike, do you want to read the next one?
Yeah, I'll read this one. I felt sorrow for my body after the cancer diagnosis. I wasn't mad at my body. Therapists would ask, do you feel your body has let you down? No, I'd reply. I feel my body got a bad deal. I talk to my breast. I'd say individual words to it. My body didn't cause this. The universe did. But the kindness to my body brought out anger too. I felt like my body's mother after someone does your child wrong. It was unfair what the universe did to me. And she continues, or I assume, anger, sorrow, kindness, all wrapped up in a bad tasting burrito with a COVID sauce on top. Thank you for that. I will say, and Naomi will keep reading, but we've been doing these a long time, and it's a real privilege to hear to be in the room as people share their deepest thoughts. It's also incredible where people go and how they interpret these themes and prompts, and how beautifully we convey to them and to you that you're not writers, you're doctors, you're patients, you're students, but you know, writing is so much heart, and what comes out is just often just joy, and it blows me away often to read it. So I'll stop prattling on and let Naomi continue reading the next one.
The next one, I cry to make a difference. I cry because there's pain. I cry because it does not end. I cry for such dark rain. Thank you for sharing.
That is beautiful. Here's one simple question. Thank God. A flood of conversation and emotion and history and trauma and palpable need for healing gushed out from the wound she sought to cleanse. She cared, kind, she shared, young. She had seen so much death in that ICU. Grateful that I was living, would live. Grateful that she was living, would live. She told me she had resigned. 2 weeks, then no more death for her. She was wounded too. And together we found kindness, healing kindness.
Thank you for sharing that. We so often look for these stories where in coming together, patients and caregivers find something together, find something shared, as we know often happens. Thank you for putting that into words.
Often, one of you, before you read the Naomi, they often, you know, we don't give you any instructions on how to write or what to write, but often they write in the shadow of what the piece we read, and we just saw a little verse, a poem, and, you know, sometimes people write in the style. It's funny how your ear and mind works of what they had just read, the piece of literature. All right.
The next one says, her heart so heavy she was weighed down, barely able to stand erect, shoulders rounded, curving into her chest, hiding, no smothering her heart. Tears washed her eyes, her cheeks, and joined in the crevices of her throat, choking her internally, burning her skin. How, what, no, not true. A voice inside screams, but no sounds escape. A cloud of loss and sorrow envelops her, stopping her breath. He cannot be gone. He is too young. The child does not leave before the parent. Her mother yearning for the touch of her firstborn is an ache like no other. I cannot live in this sorrow. I cannot live. I am begging for God's grace. Thank you.
Wow.
Thank you for sharing.
Sorrow is not a contest. My sorrow doesn't need to be bigger than yours to be valid. Must there be shame attached to my sorrow because it's not as big as yours? Pangs of guilt to mourn a loss that cannot measure up to the enormity of another's? Just let me sit with it, feel it, gently release it over time, and live with it tucked in some corner where I can go back and look at it when I want to. Let's not measure our sorrows against each other.
Someone else writes, he extended his hand to me to lift me up, help dust me off, started to share a kind word, a drink with a meal, and began to teach me about recovery with kindness and love. So we hear these stories of kindness and of sorrow. We'll have a chance over the course of the rest of the day to hear from different people as they share their stories. And as you all move through the day, whether you had time this exercise or not, I would encourage you to, whenever you're interested, take pen to paper, set your timer, and go ahead and plan to write to a timed prompt, whatever that prompt is that you give yourself. We'll go ahead and post this poem at the end of things also. I'm going to read one more, and then I also want to open it up if anyone has any questions or anything else they'd like to comment about before we wrap up this session. If you have any questions, feel free to put them in the comments section or keep sending us your writing. We love to see it. The next one says, going through my ordeal was very hard. For those among you who afforded me a sympathetic ear and time and patience, while I expelled all of my helplessness, my hopelessness, my self-loathing, all my sorrow, and especially all my deep, deep rage. I am grateful to you because now I am healing. I thank you for your gift of love and kindness. It has allowed me to become stronger for my experience. I have learned a great deal from you, and now I am ready and able to help others. Thank you. Thank you for writing that.
And thank you guys for sharing. It is a real act of bravery, even anonymously, to put your writing out there. And, you know, it's, as I say, a privilege to be able to hear and listen to your honest and deepest thoughts. So thank you all. Those who shared, thank you for sharing.
Great. So we we're waiting for a few of the questions to come in. We see them coming in. As we do, I want to put the poem up so people can see it again. And before we wrap up, I know we're coming to the end of our session. I'll read it one more time. You have a wonderful lineup ahead of you of people who, like I said, will share with you their stories. And as you listen, think about ways, we try to think about ways that people's stories are similar or different to our own. Now that you have a piece of paper out or a computer screen open, as things hit you, start a list of ideas of things that you might want to write about as you move forward, whether that has to do with the COVID-19 pandemic, recovery from addiction, which you'll hear about a little bit today, telling stories, the power of literature. You'll hear about all that today. And as you do, maybe jot down notes about anything you might want to write to yourself and commit to at the end of the day, taking 8 more minutes before you move on to your weekend, and choose one of them off that list and see what you can write.
Right. Be fearless, sit down and go for it. It's extraordinary what will come out, as we've just seen.
So for anyone who might have joined late, or as we move into the next session, I'm going to go ahead and I'm going to read this poem one more time. I think something comes in the second time you hear it. So I'm going to go ahead and read it again. And we'll think about kindness as we move on through our day. Kindness. Before you know what kindness really is, you must lose things. Feel the future dissolve in a moment like salt in a weakened broth. What you held in your hand, what you counted and carefully saved, all this must go so you know how desolate the landscape can be between the regions of kindness. How you ride and ride thinking the bus will never stop. The passengers eating maize and chicken will stare out the window forever. Before you learn the tender gravity of kindness, you must travel where the Indian in a white poncho lies dead by the side of the road. You must see how this could be you, how he too was someone who journeyed through the night with plans and the simple breath that kept him alive. Before you know kindness as the deepest thing inside, you must know sorrow as the other deepest thing. You must wake up with sorrow. You must speak to it till your voice catches the thread of all sorrows and you see the size of the cloth. Then it is only kindness that makes sense anymore. Only kindness that ties your shoes and sends you out into the day to gaze at bread. Only kindness that raises its head from the crowd of the world to say, "It is I you have been looking for," and then goes with you everywhere, like a shadow or a friend. I'll invite Charlotte to join us back up on the screen, and we can take down the poem. And I want to thank everyone for being with us this morning.
Before you go, we have a great question here from one of our participants that I would love to hear you both address. Claire writes, "I like to write about my deep sorrow in a scathing, humorous way, dark humor usually. Is that appropriate? I sometimes don't know if I'm crossing a line." What do you all, we've been very respectful and very somber, but what about using humor? What do you all think of that?
I can say that I think that when you write whatever's true for you. And if that's what's true for you and that's the way that you write and that's the way that you think or that you tell your story, then that's it. Now, when you ask me if I think you should publish that writing, I think we get into a different question. But writing is for us. We don't write for anyone else. We write for us. And before we know if it's good or bad, we like it or we don't, we have to see it all laid out on the page. And so I would encourage you never to censor yourself as you get your thoughts on the page. Now, when we touch issues of deep of deep sorrow and of deep controversy, and we think about putting those out into the world for others to read, you'll get a wide variety of opinions on how to go about publishing or prefacing those. But I'd be happy to discuss that with anyone. My personal views, but they would only be my own personal views. But if that's how your story comes to you, write, however it comes.
Yeah. The world may not get your humor, and if you try to publish, that's a risk you take. But Naomi's 100% right. That page is yours and blank, and you should be fearless and do what's healing for you to write that humor. So you go for it. And if you're lucky, you get a good editor like Charlotte who will buff it and shine it and make it, front page or wherever.
Well, and I should be honest here, the woman who asked this question is a writer that I know. She is very funny. And yes, I would definitely encourage her. Well, thank you both. This has been just delightful. And thank you to everyone who has been sharing. What a wonderful group of writers we have with us. And if you're not comfortable sharing, that's fine too. Everyone has to do you. But again, thank you so much, Naomi and Mike. Everyone, please check out what they're doing at the Temple University Narrative Medicine program. It's really, really exciting. And there are great examples on their site of the work that Naomi and Mike have done, and as well as the work of their students. They do some terrific story slams that I highly recommend. Now we're going to take a little break. In 10 minutes at 11 o'clock, we will reconvene with our next program on Philly's other pandemic. We have a really great panel of experts in addiction recovery, peer experts, who will be talking to my very talented colleague, health reporter Aubrey Whalen. So you won't want to miss that. We'll see you in a few minutes at 11 o'clock. We'll be getting going again. Thank you all.
You have the power to stop this virus.
By being fully vaccinated, you are not only protecting yourself, but also those who are unable to get the vaccine,
such as children under the age of 12.
Our greatest tool to beat COVID-19 and its variants is in your hands, Philadelphia.
And we're counting on you to use it.
Juntos hay que proteger nuestra comunidad y vacunarnos hoy.
Together we will beat COVID-19.
Hi, everybody. I'm just going to get started here. My name is Aubrey Whalen. I'm a health reporter here at the Inquirer. I cover addiction, health disparities, and sort of virus-related topics as they come up. It's been a bit of a crazy year for all of us. So this panel is called Philly's Other Pandemic. We're going to talk about addiction and the overdose crisis here in Philly. And we've got three panelists here who work very closely with people in addiction. We're going to talk about their stories, their client stories, and how the COVID pandemic has changed their work. So I'm first going to just start with some housekeeping stuff. If you would like to submit a question to the panelists, please put them in the comments section at the bottom of this page. You have to be logged into your inquirer.com account to submit a question. So you can either log in or create an account using the sign in or sign up button in the top right corner of the page. So first I'm going to bring in Nicole O'Donnell. She's a peer specialist at Penn Medicine. Hi, Nicole.
Hi, Aubrey.
Thank you so much for being here.
Thanks for having me.
And we next have Pete Dunmore. He's a certified recovery specialist at Prevention Point. Hi, Pete. And we also have Mike Hinson, who's the president and COO at Self Inc., which is the largest emergency housing provider in the city. Hi, Mike.
Hi, Aubrey. Hi, everyone.
Thank you guys so much for being here to talk about such an important topic. I really appreciate it. And I know the last year has kind of been unlike any other in healthcare in general, but also in the line of work that you guys do. So I was wondering if you could talk a little bit first about what sorts of challenges people in addiction and recovery face during the pandemic, and maybe talk a bit about how your own work changed.
I could start.
Yeah, please.
I could start. My work changed a lot because my milieu is the emergency department, right? So our patients didn't want to go to the emergency department because of the COVID, in the beginning of COVID, especially. So a lot of our work became virtual, which, for our population isn't ideal. It was really hard, like as a person in recovery and as, a person who wants to be there with people. It was really hard to have virtual visits on an iPad when patients did come to the emergency department. So the virtual work was hard to connect.
Yeah. Pete, what can you tell us a bit about what you do at Prevention Point and what changed, as when the pandemic hit?
Well, here at Prevention Point, I'm a certified recovery specialist. I stay connected with those that's in recovery, that's going through recovery, to keep them linked with detox and rehabilitation centers, medical, also with the homeless, with shelters, medical assistance. We link them with, trying to help them get their benefits if they need benefits. But basically it's trying to keep them updated with their medication, to make sure they stay updated with their medication. But during the pandemic, actually I had worked for another program that closed down for a few weeks. And at the time, worked at their shelter, and it was still, it was bad trying to keep them connected with resources. And, as she said, hospitals was closing down, you couldn't get in. Participants had a bad time trying to get those services as well, and it was frustrating to see that they can't get the help that they need behind the pandemic. Fortunately, I was able to stay at work through the pandemic. And it was hard. And with the mask, like wearing the mask was kind of rough with participants as well, you know, because a lot of times we don't understand why we have to wear these things, you know, coming from our own normalcy to a new normalcy. You know what I mean? So it was hard. It was rough, and dealing with, you know, just them not being able to get services.
Absolutely.
Yeah, I jump in, Arbor, if that's okay.
Please.
Certainly, we experienced, you know, similar things that Pete just spoke about. I also think, though, that what the pandemic also provided us is a chance to look at just how much our systems really needed, you know, really need a rework in so many ways, right? Certainly, we had folks who in emergency housing who loved the fact that we had such good mitigation plans in place because they wanted to be alive, right? They wanted to be alive. And then there were some folks who had difficulty, you know, just had difficulty with wearing the mask and those kind of things. I think one day I was at one of our sites and a person came in, this was early on in the pandemic, a person came in from getting their treatment, and they came in with a bag of pills, about 100 pills in a bag. And we all thought, and the person thought, wow, this is like, so we have a system now that's going to give me 100 pills at one time for my treatment. I'm going to be responsible for it, right? But all along, you know, before this, it's like, oh, you got to go in every day and you got to meet by this time and you got to do this. And it really shows us that some of the things that, you know, our systems have in place really are not necessarily the best ways of doing things, like giving people a little bit more control over their life, a little more flexibility over their life, really goes a long way when a person knows that, you know, they're taking the right steps to, you know, to be in treatment and to be in transformation. But I think, you know, the pandemic has been really, really brutal. It's been brutal. Right. We should make no mistake about that. But I think it's, again, also, it's just showed us, you know, where there are opportunities to improve the system for folks and with folks.
Yeah, I remember writing earlier this year a story about people who were on methadone who were very used to going to clinics like every single day. And when the pandemic hit, they would, you know, they were getting take-home doses, and, you know, this was like a whole new thing. People really, really liked it. And it was like a little bit, you know, a little bit of like normalcy or control in what was otherwise a very, you know, difficult kind of upended time. But yeah, I do think that your point is spot on, that, you know, the way that systems had to change to accommodate, you know, the pandemic has really showed kind of what's necessary or what's not, or at least what we should be thinking about.
And sort of like the outdoor eateries, my hope is that, you know, if we're going to keep outdoor eateries forever now, then some of the practices and some of the things that we had to do that we're doing during COVID, we should, you know, really try to change the system now. We know that it's possible.
Right.
Yeah, I mean, did any of your, like, going off that, did any of your perspectives on how to work with people in addiction, or how to, you know, work within these systems change as a result of, you know, the changes that you saw during the pandemic, from whether that was, you know, it's easier to get Suboxone, or the methadone restrictions have been relaxed, or?
I think that's one of the biggest silver linings for me in the COVID was the decrease in regulations around buprenorphine prescribing. We were able to do a lot more low barrier engagement with physicians being able to prescribe virtually. So that was one of the biggest silver linings for us.
Yeah. Oh, and for people who aren't familiar, can you explain what buprenorphine is?
Yes. So buprenorphine is also known as Suboxone. The buprenorphine's the generic name. It's a medication for opiate use disorder. It mitigates cravings. It reduces overdose by 60%. So it's a medication that you take daily. And it's the evidence-based treatment with methadone and Vivitrol for opiate use disorder.
Thank you. And I'm sorry, I totally interrupted someone as I was like, what is buprenorphine?
Yeah.
Did Peter or Mike, did you want to chime in?
I think it was Pete was going to say something.
Well, just the fact that, you know, it just caused a more collaborative conversation between service providers and those at the clinics, you know, to get closer with scheduling appointments for those during the pandemic. And she said that, you know, like the methadone clinics, you know, were sending people home with like weekly doses or monthly doses or whatever, you know. And then it was the fact that some clinics wasn't accepting new participants at the time, or, you know, following a guidelines of how to get serviced, you know, for participants. And there was a lot of frustration, you know, when participants go there that they wasn't seen or couldn't get seen because of the pandemic and the rules that they had set in place to be seen. So, you know, and it was, you know, trying to find alternatives or set up, you know, the next time someone comes in there, you know, you have to have a plan B, you know, for when that situation arises again, that treatment center number 1 is not running up to par. We need a treatment center number 2 or treatment center number 3, you know, and it gets frustrating to participants that, you know, that they got to go from where they are comfortable with going to go somewhere uncomfortable just to get treatment. But this, you know, dealing with the Suboxone clinics, to me, Suboxone clinics ran very well, you know, for, you know, here at Prevention Point, you know, for participants I was doing.
No, you're right, Pete. It was really hard because getting someone inpatient, all of the requirements changed because of, you know, the COVID restrictions, and there were less beds, right? Because they had to decrease their populations and their beds because of social distancing. So, no, you're right. All of the what we know, the resources that we know how to connect people to, it all changed. So we all had to relearn everything. The participants had to relearn everything. It was hard.
Yeah, and you know, if you think about emergency housing and folks living in emergency housing and, you know, coming in, you know, with, you know, their treatment, right? Coming into the emergency housing with their treatment, and, you know, how do they manage that, right? In emergency housing with, you know, 50 other people, 60 other people, you know, having to, you know, put the medication up for them, hold it for them, and making it available to them, you know, at the times that they absolutely, you know, need it. It changed a great deal of, you know, how we had to think about working with our participants. I mean, the other thing that I think it did is it gave us more of an opportunity to really, really listen. You know, we always thought we were good listeners with our participants, but COVID, you know, because we were all indoor, right? We were all indoors for the most part. I mean, certainly folks went out and, you know, did other things, but we spent a lot more time with our participants during COVID, right? And so we got to hear more. When we got to share more, they got to share more, and we got to learn, like, you know, this piece of your program doesn't work for us, and you need to change it, or you need to think about changing, or you need to be more flexible. We had times when, you know, there were times when I think as a system, we thought we were getting out of COVID, right? And so we started relaxing some of the mitigation. And then all of a sudden it's like, nope, it's back again. And we had to put more mitigation back in place, right? And so those changes really disrupted, you know, people's lives, right? And so it wasn't just, you know, folks who, you know, went home every day whose lives were disrupted. It was, you know, folks in our emergency housing system, their lives were always disrupted, you know, as a result of COVID and all of the new rules, and you're doing it with, you know, 40 or 50 other people, right? And so we learned a lot. We've learned a lot. And I think, you know, we just need to say we learned a lot, and we can use this as an opportunity to improve the systems, because it definitely needs work.
Yeah. Mike, you mentioned, oh, go on, Pete, sorry.
Also, you know, not to change the subject of medication, but it also was the same even with those of the homeless, you know, the shelter systems, you know, less beds, you know, everything had its own protocol and policies of what they're going to do or what they're not going to do during the pandemic. And it just shut a whole lot of things down. And it comes back to, again, loving your work and going the extra mile to figure out how we can make it work for those that get rejected, you know, trying to get in, whether it's the medication, whether it's a shelter, emergency housing, whatever it may be. You know, I'm not going to say it put a strain on us. And like Mike said, it made us listen a whole lot more of what we can do or dig deep within ourselves and make us collaborate with other people too. You know, our coworkers, you know, like, hey, what do you have on getting this person in, because I just called XYZ and they don't have a place. You know, they stopped taking people. And then it's a certain time during the pandemic that they had to make it to these places to get in, you know, extra early, like 3 in the afternoon, and you're not ready to go to bed until 7, 8, 9 o'clock at night to settle down. And they got to, you know, there. And there's not that many places throughout the city, because at one time there was, like you said, no beds nowhere, you know, for you know, whether it was detox or a shelter.
Yeah, Pete, I'm glad you mentioned our colleagues, right? Because that's the only reason that for me, that's the reason I got through the pandemic, was all of our colleagues jumping in and trying to figure it out for all of the people, and leaning on that. We needed them for support too, because of our own recovery, right? So I really want to give a shout out to all of the colleagues, all of the grassroots organizations that just figured it out.
Yeah, I mean, all of you are kind of saying, you know, bringing up the importance of listening and the importance of telling stories, which I feel is such a huge part of recovery. It's, you know, kind of helping people to kind of figure out their story, listening to other people's stories, you know, that this is a part of the healing process. But like, when you said you learned kind of to listen more, to listen better, like what did that mean for you? And what were patients telling you? How were they telling their stories differently? What were they coming to you with that you hadn't heard before?
Well, they were participants would come in with their struggles, their rejection issues, their personal struggle with life and dealing with what they're dealing with, recovery, homelessness, illnesses, whatever it may be, and they come in and it allow you to listen, especially when you come through recovery. I had a coworker that gave me a line that I used, and I never heard it before, and he made me look at myself, and he said to a participant, "When I look at you, I see myself." And I said, whoa, you know, it made me think about it. And that's what they do when they come in. It always reminds you where you come from. If you are a recovering addict or you have been in a life of addiction or on your own. And when they come in, it's hard to hear the rejections and just move on. It makes you, I mean, when you don't want to do it, it makes you have to reach out to a coworker, you know, or another agency, and we get together. We can't change the policies of what those treatment centers have or whoever they have. We can come as a whole and like I said, and just listen. And it's heartwarming. It's overwhelming, some of the things that is said to you. Some things are very personal that you would never believe someone would say to you. And it makes, like, again, like I said, it makes you dig deep down within yourself and it motivates me to go that extra mile that I should already be going from the beginning. It just pushes you. It's like when you don't have that last breath, it comes from somewhere and makes you move a little harder. And that's what listening does from participants. You know, that's what it does to you.
Yeah, I remember. I remember again, one day I came into one of our sites, and a father who was living in the site talked to me about our mitigation plans, and had a whole bunch of anxiety about the mitigation plan, because we had, you know, certain times that we wanted folks to be in, because, you know, we wanted, you know, we're just trying to control, not have any outbreaks in, any of our sites, right? And so he said to me, he said, the problem with the mitigation plan is I really need to see my son. Something as simple as that. I need to see my son. I need to be able, those systems of support that are outside of our emergency housing sites, right? Folks still needed those support systems, right? The mitigation plans interrupted your ability to have those support systems on top of, the medication piece that we already talked about. Those support systems are critical to people's transformation. And so, I listened to him and we listened to him and, just had to be more flexible during COVID, because that people were experiencing a tremendous amount of anxiety and stress as a result of COVID, as a result of being homeless, as a result of being, in transformation, in the act of transformation. But we had to be a lot more flexible so that this gentleman could go and see his son, and that would help him get through the rest of the day, or go and see their mother, because the mother was living alone. And she was not only his support system, but he was her support system, right? And it was at the same time that we were trying to say, we don't want to have all these contacts with all of these people. But, when you're faced with fighting the pandemic, you're fighting your recovery, you're fighting the violence in the community, all of those things, you throw it up in the air and you pick something, right? You pick something, whatever lands you pick, and you try to make the best of it. And that's unfortunately what a lot of folks have had to do through this pandemic. Pick one thing over the other just to survive day to day.
Yep. I mean, one of the things that struck me from the very beginning of, when we began to cover this, was that the immediate advice to avoid this is, before the vaccine, before even there was a masking order, was, stay away from other people. Don't leave the house if you don't have to. Just don't go out. And this completely flies in the face against every advice that, we have for preventing overdose. Don't use alone.
Isolation. No.
Tell people what you're up to, connect with people, be in community. And that was just not possible for the first half of the pandemic.
And not to mention the drug supply changed rapidly.
Yeah. Yeah, I was wondering, could you talk a little bit about that, about, just like what it was like on the street, to what people were saying about, how the drugs were, changing or what was in them?
I mean, we didn't really know what was in them, but I know that we saw an increase of the tranquilizer in there. We did see a lot more of the counterfeit pills on the streets. So people didn't know that they were using fentanyl. People didn't know that, there was fentanyl and cocaine. So we saw a lot of that, and we're still seeing a lot of that. So we had to, what do? You flood the streets with Narcan and fentanyl test strips. You educate the community. There's communities experiencing this that don't know that they're experiencing it. So this is still going on currently. So that hasn't changed or gone back, and we don't think it's going to. I don't think it's going to, the drug supply is going to improve.
Yeah, I mean, and that's the other thing too. And, I wanted to ask about this as well, is we saw this a demographic shift in overdoses this year. Yep. From, it was mostly white Philadelphians dying, and now it's mostly Black Philadelphians dying. And this is a national trend. This has been coming for several years, and it sort of finally, it occurred, in 2020 and for the first time in Philly. Yeah, I mean, and Mike, you and I have talked about this before, and I know that SELF has gotten a grant from the city to kind of try to do specific outreach to the Black community around the overdose crisis. What do you see as just kind of how this community is coping with, both the pandemic and the overdose crisis?
Yeah, I mean, again, it's like we have overdoses increasing in Black and brown communities. You have the violence issue that's happening in Black and brown and poor communities. The education system is, what it is, unfortunately. I mean, our communities, continue to suffer the brunt of, I think some folks used to say, if one person gets a cold, our communities get the flu. right? And that's what we have. That's what we have. And, certainly, we decided as an organization that it was important for us to start being better messengers about opioid use, about overdoses and overdose deaths. We decided before we got a $50,000 grant from Vital Strategies in the health department, we decided that it was important for us to be a better voice, right? Because our communities are so far behind when it comes to understanding how overdoses are happening in our community, what leads to them. My sister recently passed from an overdose, right? And just the lack of education about just the medications, and that, fentanyl is in every single thing you can get on the street. Fentanyl is in it, right? And so to me, it just means, our public health infrastructure has to be a lot more responsible when it comes to working with, specifically with Black and brown communities, but poor communities, right? Because our poor communities don't have the same kind of infrastructure to deal with, these new things happening that some other communities have, right? And so we're always saying to our communities, oh, you're so resilient, without understanding that that's a stressor right there, that I have to be resilient on so many different things all the time. Like there's the ideal that you can actually prevent an overdose, right, by putting test strips in people's hands and having them test their drugs every single time. You then don't have to rely on your resilience because you've prevented the overdose, right? So teaching folks and giving those kind of tools to every community, not just Kensington, but every community. The overdoses that are happening in Black and brown communities are mostly happening in people's homes. So that means that our strategy for reaching folks needs to be different. We can't have a one-size-fits-all strategy, period, right? It doesn't work for individuals and it doesn't work for communities. We have to have a toolbox that's available for folks, and folks can say, this part of the toolbox works for me, right? An elderly grandmother who, has had a back injury or who's had a knee surgery, that now is, in recovery or fully recovered and doesn't know where to take the medications that they have in their house. And so someone else gets them. Like those kinds of just informational, educational things, drop-off places where people can take the medication, just those simple things. That's how far back some of our communities are and don't understand, when these deaths happen, that they actually are preventable. They really are preventable, right? And we just have to have a better public health infrastructure to help people get those tools and get those messages. And the program that we have, we're certainly, excited and doing the work, but think about it, $50,000 to think about it.
I couldn't agree more, Mike. We see a lot of patients come in the emergency department from the West Philadelphia community that don't know they're using fentanyl, don't have any awareness that there's treatment for opiate use disorder, don't think that they have opiate use disorder. There's a lot of awareness initiatives that need to happen. I mean, we're also doing our best to do that, but it's going to take a lot more than $50,000 to educate the community that needs to be educated.
Absolutely. And like you and Pete said, Nicole, it also means we have to also rely more on each other. Mm-hmm. Our systems, unfortunately, are so disconnected. They're siloed, right? And so people get one piece of something over here, others get another piece of something over here. And by the time you figure out that all of these things are connected, it's like we really have to figure out a comprehensive approach that ties all of us together with our folks in our communities so that people aren't having to pick a box to be, you know, have to sit in one box and say, okay, I'm only going to get this from my medication. I'm not going to get it from my peer supports, right? Or I'm not going to get it in my housing supports. We have to figure out, we have to have a system that puts all of it together, because people shouldn't be forced to make those kind of choices.
I have a question from the audience that I think is kind of sort of tied into this. Do any of the panelists use storytelling to help you process the traumas of the past year or your lives in general? And I wanted to bring this up because I know, you know, Nicole, you've been in a peer support group, like a support group for peer supporters for the last year. What is, I mean, in terms of like, just like, do you guys talk to each other? I mean, when you're talking about, you know, you have to get out of these silos, like, you know, about your own personal stories. What do you talk to each other about? Like,
yeah, so that's a great question. And that's another silver lining of COVID. We've realized that our peers that are doing the work, that are in recovery, needed the support too. So we created the peer support meeting for peer supporters. It's the longest name ever, but it's very specific. So we had to use storytelling. We had to process traumas with each other. I mean, if we didn't, and we know that that's how, like, the best way to deal with trauma, right, is this processing it with our peers that have been dealing with the same thing. I mean, we're still losing people at a rapid rate. Like, our patients, our colleagues, our family members, and I'm sorry, Mike, are dying. So we need somewhere. We need the safe place to be able to process that. And I'm super fortunate, and I know how privileged I am to have support from my colleagues and my friends and everybody doing the work, but not everybody has that. So that's why we wanted to create the virtual space to be able to do that, because it's hard.
Yeah. I mean, Pete and Nicole, could you talk a bit about, you know, what you did to maintain your own personal recovery during the pandemic?
Actually, I stayed connected with those that's in recovery. I have a lot of peer support. 25 years I have under my belt. Thank God that I have 25 years of recovery.
Congratulations.
Congratulations.
That's great.
Mm-hmm.
You I like this. Everybody's recovery that I've learned, everybody's recovery is different. Everybody take their path of recovery is different. Sometimes, as Nicole said, I love when you said the support peer groups, because we need that to keep each other strong at times. We don't know who's feeling weak. A lot of people don't share when they're feeling weak, especially as men. You know, we like to keep a lot on our shoulders and go out through our day. And I believe that the peer group is very good. But through my pandemic, you know, again, it pains me and it hurts me. And I really thought I never would say this in my life from my background, that it hurts me to see in the way the community is living, you know, through addiction. Like now, I'm speechless because it like Mike said, it's the education, and then it's like getting them to learn what's going on, and not just learn it or hear it, but to hold on to it and use it. And Nicole, again, elaborate what you said in West Philly. It's none of this in West Philly. Let me stop. It's beginning to pick up in West Philly, because I'm from West Philly. I never seen it before until I came to Kensington. Even years ago, as an HIV tester and counselor, I worked on the Kensington Avenue in a little storefront place. But teaching our parents, teaching our brothers and sisters that don't use, it's the start. It's just like, you know, your children, you know, when they do something in the street, they say, yo, where the parents at? It starts from home. Even if those that we see and work with people that been out in these streets for years, and sometimes, you know, it's hard when they say, I can't go home, you know, because how they treated home and messed home up, and home got messed up because home did not know. Home did not know how to support their children. Home did not know how to support those that are currently addicted to whatever it is they may be addicted to. All we know was to put them out. They're not allowed in the home. But when you know it's a loving one that you should love with all your heart and get them help, we push them back out in the street, even as far as the community. We do the same thing in the community. You don't have to be my child or somebody. I see somebody bent over or laying on the sidewalk. We walk right past them. As a community, we walk right past them, and knowing that they having issues. Even as community members, you know, we teach the police in the diversion programs what addiction is, and when they see addiction, how to do and treat those in addiction. Some people never seen it before. Right. But now when you see it, it's hitting home. Nicole, West Philly, it's hitting home. We have to learn to teach each other what's going on in our world, in our Black and brown communities. Black and brown people in the Black and brown community, we don't know how to treat each other with love, whatever percentage of the time, and it's a high percentage. We need to learn how to wrap our arms around each other and say, hey, or extend a hand and say, come on. Not leave them there and turn the community into something that is far worse than what it is today.
Michael, we have a question. Oh, go on, Nicole, sorry.
No, I love that, Pete. Thank you. And again, sharing the hope really was how I got through the pandemic with my peers. So we know that peer support works in our work, but it also works for us and helped stay in recovery. It was really cathartic to be able to process with people that have also experienced the same thing.
And how do you guys like disseminate those stories to people who need to hear them, you know, beyond the peer support group? I mean, do you, when you're working with people in addiction, you know, especially in the last year, did you talk about your own experiences? Did you, because I wonder if it was harder just because, you know, so much had changed in the last year. That was such a crazy situation, like, you know, to be like, yes, you can't really say like, I've been here too, when, you know, no one's been here, that we're in the middle of a pandemic.
Well, all the stories are the same. You hear the same stories over and over again through different people, but you just hope that no matter where you go, that one day whoever you're talking to will hear you. I speak for myself that I'm different through my recovery, very different. And yes, I share with people when it's on my heart to share, because some things, I'm not going to say some things ain't for everybody, or it's not in me to share or given to me to share. But I say a whole lot of time, I do share my you know, what I've been through. And a lot of times, you know, I keep it to the point. I tell them, I've done the same things you've done. I done slept on the same streets. I done ate out the same dumpsters or the back of the restaurant dumpsters. I done picked up the same cigarette butts off the ground, you know, the smoke. And it's sometimes I just hope that it's a warming feeling to them, that, or motivation that, hey, here's somebody that been in my shoes, and have that much time clean, that could be me. And, you know, a lot of times I say, it is you, you know, it's you. You grab it, you know, with a kind heart, you know. I just tell them, grab it. You know, here at Prevention Point and other organizations, we do the legwork for you. All you have to do is show up, you know. And if you have a problem showing up, you know, you have a phone or can get a phone because you have my number, I'll come get you. I will come get you when you're ready to go. So, and yes, there's sometimes the story sharing does spark something in somebody's life, or the light bulb does come on, or it makes them say, you know, and whatever. And I just hope that it's the part of the story that I'm sharing grabs you, you know, at least grab you, or at least make you come back tomorrow, or, you know, when you can. I hope always hope I see you another day inside where I work or on the street, or you saying, hey, I'm ready to go and detox right now, just by sharing. And, you know, it has come back to me, you know, and I didn't know how to take that either. I didn't know how to take it and say, if it wasn't for you telling me when I came in the office, I thank you very much. And it comes back from the people that you haven't seen maybe in 2-3 months. They come back and say, I just got to shake your hand. I want to give you a hug. That, you know, what you said to me, open up. And, you know, and it's a blessing.
Hey, Aubrey, I see this question from the audience about how do you reach people in their homes?
I was about to ask that.
Yes, Sterling Johnson's asking a question about how do you reach people in their homes when drug use is so stigmatized and those people are dying in their homes. He says, I know that is a difficult question, just wondering people's views on it. And, you know, this is Reverend Wells, who was the founder of One Day at a Time, used to say, you have to be where the rubber meets the road, where the rubber meets the road. And this is where the rubber meets the road, right? And so what we're doing at Self is, you know, we have folks who are in transformation. We are using our dollars from the health department grant to pay folks who are in transformation, give them training. They go out into community. They put door knockers on doors. They do pop-ups at transportation hubs or corridor hubs, right? So that we're actually in community, right? We're in those communities where this information isn't getting as much as it's needed, and you know, going door to door. You know, going to those transportation hubs, giving people the fentanyl testing strips, teaching them how to use the testing strips, talking about what they can, you know, how to store and make sure medications are in safe places where children and young people and people my age and older, you know, don't get to them and you know, get on the track. It's not going to be healthy for them, right? But it's so much more needed. And Sterling is right. Our communities do have, you know, stigma around, there is stigma around drug use, right? And so there's a lot more conversation that needs to happen in our communities. But it's interesting that Pete, you know, talked about when he used to be a HIV tester. It's sort of like that time period where when HIV, you know, was such a pain in the rear, right? That no one wanted to talk about it. No one wanted to be honest about, you know, elderly people still having sex, young people having, no one wanted to talk about it, right? And there are all sorts of cultural reasons why some of that stuff happened. But the other side of that was people were dying, right? The kind of deaths that we're seeing from COVID, that we're seeing from overdoses, over 3,000 people have died of overdoses in the last 3 years in Philadelphia, right? So we have to, you know, it's like, we have to now be brutally honest with ourselves. This is what we're up against. It's live or die, right? And it's happening in so many places that we just have to say to people who are uncomfortable. I know it's an uncomfortable conversation, Mom. I know it's an uncomfortable conversation, but we don't want to lose another brother. We don't want to lose another sister. We don't want to lose another auntie. I don't want to lose another friend. I don't want to lose another sister, right? So as uncomfortable as it is, we have to have these conversations. We have to have everyone who can have the conversation should be having it. Our barbers should be talking about it, and they are. There are barbers who are talking about it now in barbershops. Our hairstylists should be talking about it in the beauty salons. Our pastors, our imams, everyone should be talking about it because it is very, very dangerous. And 40% increase in the last year over those deaths. Those are deaths. Those aren't overdoses. Those are the deaths, a 40% increase in deaths. Imagine how many people have actually overdosed and how that actually affects their quality of life, right? How that affects their household, their children who live in households, right? There's so much more work to be done. And frankly, I'm kind of surprised that our system itself hasn't really rapidly responded to this. In, you know, it used to be something happens and they put together this big expert group of people who would come up with a strategy. You know, we try out the strategy and make sure. You don't see that happening. It's the sense of urgency from our public health infrastructure is not what it needs to be when you're talking about Black and brown communities dealing with gun violence, dealing with overdoses and overdose deaths, dealing with the pandemic, right? We started at Self, we started doing managers calls, talking about telling stories every single day just to support each other, right? Because a good number of the people who I work with every day, loving people, committed to community, they go home to families and loved ones who are dying from COVID, who are dying from gun violence, who are dying from overdoses, right? These are folks who are working with people every single day. And so we said, you know what? We got to have a better support system. We started having calls, managers calls every single day. We're down now to twice a week. But we had them, you know, during the whole pandemic. We had them, you know, we just recently started doing it every 2 weeks. But the sense of urgency from a public health perspective, I just don't think that it's where it needs to be. And certainly the resources aren't in all of the communities that actually need them. And let me just be clear about this. We need more resources in Kensington. We need more resources in Kensington. And we also need more resources in West Philadelphia, Southwest Philadelphia, North Philadelphia, other parts of North Philadelphia. We need those resources, right? We need that education. We need this collaboration to be happening better. And we actually need a better plan, right? We need a better plan. Increase the amount of mobile treatment options. Increase that. And not just have it in Kensington, have it in Southwest Philly.
Yeah.
Have it in West Philly.
Yes. Yes. Because that's an issue with a stigma or issues with the brown and Black communities, that it's not enough. Getting from point A to point B is the issue. You know, you tell a participant where to go on Tuesday. Why just Tuesday? You know, and like Nicole said, and you just said, there's not enough resources in those communities. You got a bus, you know, Prevention Point has a bus that goes certain communities once a week, you know, to different places. We need one there every day.
Yeah,
we need somebody there every day. You know, John Doe might not have an episode on Tuesday. You know what I mean? And Tuesday is the day that the bus was there, and you know what I mean? He missed out. That's a lack that needs to be picked up. You know, even educating those who don't use, you know, I worry about them listening, because like I said, we walk over people in the Black and brown community. We walk over folks. I'm not gonna lie, I see it. You know, we make fun of people, you know, drug dealers, those who don't use. It's like a plague, you know, when we see someone going through an episode of using, you know, dipping or laying on the floor, or, you know, just not right, you know.
Well, you know, one thing though, Pete, I would say about that is sometimes folks don't know how to respond, right? how do you respond? What do you do? How can you help? It's like the idea, like you see someone, who's, actively going through, something right this second, and you don't necessarily know, well, what do I do? If I don't have Narcan, or I don't have the training, or I just don't know enough about it, how do I actually help? Right. And then people are also picking their pain, right? People are picking their pain. It's like, listen, I just left a house where, my children don't have enough food on the table. So I'm not just walking past somebody in the street. I'm dealing with all of these things at one time. And this is where this disconnect, from a public health perspective, this disconnect has to get much better, because people are having to pick, right? Having to pick, my family don't have enough food. I can't worry about this thing over here, or be involved in, helping people in this way over here, because there's so much pain that's going around. And we don't have a real plan. It's like, okay, we just added COVID on top of everything else that people are dealing with. Right. But we expect people to be resilient. We expect them to be resilient. And they will be. We will be. We are. We love each other. We care about our communities. There are tons of people in communities that are doing awesome, awesome work that we never even hear of, right? I mean, it's the survival that many of these communities have to do all the time. But hey, come on, government, come on, private businesses. Come on, private businesses, be a part of this solution.
I also think that when we talk about, the demographic shift in overdoses, the way that the overdose crisis has been covered in the last few years, I mean, it's been stereotyped as this white suburban crisis that, that the attention that it's getting is because, finally white wealthy people are like, oh my goodness, it could happen to us. And I think that, if from my perspective, from a reporter's perspective, from a storyteller's perspective, unless we start, telling stories of other communities with the same sympathy, empathy, detail that the white community has been afforded over the last 10 years regarding the overdose crisis, we're doing other communities that are now suffering a disservice.
So true.
And, we're not gonna be able to, to reach solutions if we're not, telling stories of people who have not gotten their stories told historically.
And tell them with the same compassion, right? Yes. Tell them with the same compassion. Don't just talk about, Black folks who are, dealing drugs.
Right.
Don't just talk about it from that perspective. Talk about it with the same compassion. My sister was a loving mother. A loving mother, right? She was a loving daughter. She struggled with pain. She had pain, emotional pain. Like a lot of folks do. She unfortunately didn't have all the tools. She didn't have all the tools. And we didn't have all the tools to support her and to know how much pain she was actually in, right? That whole mental health piece of it. The whole mental health piece of it. Talk about stigma. Ooh. Yeah, we got to connect these dots to keep people alive. One thing I really just want to say very quickly too is we're now seeing an increase in HIV as a result of injection drug use, right?
Yes.
And we're still having a darn argument about syringe exchange in our state. How dumb. How dumb. We know that syringe exchange saves lives, period. We know that. We have all of the data in the world, especially, over the last 30 years of prevention point. We know that it works. So we shouldn't be having an argument about whether or not, Pittsburgh or some other place can have syringe exchange, right? The other piece is when we talk about, the white suburban piece of this, the overdose pandemic, we'll call it that. When cities and communities want to bring more money into their communities, they find ways to work together, right? I remember when there was this whole conversation about the arts community, and the arts community from Bucks County and Delaware County and everybody in Philly, they all started working together to bring their resources together. Do the same thing around treating people, getting people into treatment, getting people the services and the support they need, so they don't have to leave Bucks County to come to Philly. They don't have to leave Norristown to come to Philadelphia. They don't have to leave Camden to come to Philadelphia. Think about how we should be working together, right? As community.
Yeah. Guys, we have just about 5 minutes left, so I just want to wrap up by saying thank you guys so much for coming. And just on a closing, I was wondering, you know, in just a few words, like, you know, what have you learned in the last year from this pandemic? What do you want to take away from these experiences? What do you want our audience to take away from, you know, what they've heard today, and kind of, you know, moving forward, what can we do to fix this?
Just get educated. The community, as far as the community base, get educated about what participants are going through, to really adhere what's going on, you know, and like you said, be more compassionate towards those that are down and out, you know, on their last limb, or, you know, but you might, how, you know, stop being judgmental, you know, towards those that's out there. What I didn't say was this was a new field. This was a new field for me. Actually, it wasn't, but it was. As long as I've been using, I just didn't know it. But coming to work, you know, in a place like Prevention Point, you know, seeing the overdoses, experiencing it, and being a part of overdose reversals, you know, really opened my eyes, you know, to a lot that's going on in Kensington, going on as far as how severe and serious this is, you know, from, like you just said, syringe exchange, harm reduction, risk reduction, you know, it's a lot that we need to learn. And like I said, when you, like, how we get them to understand, you know, it's getting them just to hear you, you know, you know, to what's going on. And I learned, like I said, that's what I learned. How everything is how can I, what can I do, you know, to make it better, one person at a time or 10 people at a time, you know, and even my own, you know, co-workers and my peers, same thing, you know. I need them all, even you guys. You know, I just met you today, you know, and I hope that we can continue. Or watch this, I can lean on you, Mike. I can lean on you, Nicole. You know, not just today, because we here.
Absolutely,
live. That's right. So it's every day counts. I can use something from everybody. You know what I mean? And I hope that's what the community will learn.
Yep. I learned how resilient we are. I learned that we're going to figure it out no matter what. And I learned that we don't need all the barriers around people accessing care. And I learned how important,
yes,
we didn't already know, but how important compassionate engagement, creating a safe place for people if they're using or not using or want to access treatment, how important that is. That's what I learned.
Yeah, I want to just echo what Nicole just said. We are in a time when we are dealing with breaking down racist systems and structures and all of those things, you know, and I've learned that this is a time of opportunity. The same way that we're talking about, you know, structural racism, dismantling systems that have, you know, been harmful to so many people, especially Black and brown people and poor people, that the same thing can happen, you know, just with this topic, with overdoses and overdose death. The same thing, use our innovation. This is an opportunity. This is a time for us to say, you know what? This pandemic has taught us that some of the things that we thought we had to do to give people access, we actually don't have to do, right? And so at the same time that we are looking at these structural systems that have harmed too many people, we could say, let's use our innovation. Let's take out this barrier. Let's take out this roadblock to people being in transformation. Let's make more things available exactly where people are. Why does a person have to come into a structured building to get some help? Why aren't we just, using the mobile vans? Why aren't we using our foot traffic to go out to where people are and give them an ounce of hope, just an ounce of hope? Because as Pete said earlier, it may be that one day when you go out that one day and you speak to someone or you give someone, you help them to get an ID, that one day, they may not come in that day. They may not be in transformation on that day. The next day you go back, you do it again. And eventually something clicks, something happens, right? And that hope is awoke in folks again. And that's when people begin to change. But to require people to come into structured buildings, require them to, do it on your time, do it the way you did it, not taking, into consideration their own trauma, their own experience, what has worked for them. People know. People are experts at being themselves, right? That's what they're experts at. And we have to be able to understand that and listen to that. And embrace that as much as we can so that people don't feel like the fence is so high, I can never climb it.
Thank you guys so much for all of this. I could honestly talk for another 5 hours. Your insights have been
I love talking to you anyway, Aubrey.
I love talking to all of you. Thank you guys so much. And your insights have been so interesting and so powerful. And I hope we can continue these conversations in future. At this time, we're going to break for lunch before we come back for our 1 p.m. session with Dr. Rita Sharon for Why Does Narrative Medicine Matter? We hope you're enjoying the program so far, and we'll see you back here at 1. Thanks, everybody.
You have the power to stop this virus.
By being fully vaccinated, you are not only protecting yourself, but also those who are unable to get the vaccine,
such as children under the age of 12.
Our greatest tool to beat COVID-19 and its variants is in your hands, Philadelphia.
And we're counting on you to use it.
Juntos hay que proteger nuestra comunidad y vacunarnos hoy.
Together we will beat COVID-19.
Good afternoon, everyone. Welcome back to Telling Your Health Story. We've had a morning full of great stories, and the afternoon is looking every bit as strong. Our next speaker, Dr. Rita Sharon, is the physician and literary scholar who originated the narrative medicine field, and she is the chair of Medical Humanities and Ethics at Columbia University. Check out the website, narrativemedicine.org, and you'll see the phenomenal breadth of what Dr. Sharon and her colleagues and students are doing. It's such a rich and exciting field, but Dr. Sharon sums up her work very elegantly. She told me in a recent email, "We clinicians have had to learn how to listen, or witness, or perceive, or absorb all that patients transmit us of their illnesses and health and fears and hopes. It is in the telling itself that the healing occurs." Dr. Sharon's program is different than the narrative medicine presentation that we enjoyed this morning from Temple, but they're the same in that they are both full-on participatory events. So do get ready to use that commenting feature on your screen. If you've had any trouble finding it, just go on your screen down below the schedule. You'll see a button that says View Comments, and click on it, and you'll see a blank form that says Join the Conversation. And that's where you can type in your observation or your question for Dr. Sharon and hit enter, and we'll be away to the races. So with that, let's welcome Dr. Rita Sharon to our stage.
Thank you. Charlotte, thank you so much, all of you. Thank you so much for making this happen and for believing in the power of stories, not only in life, but in lives. A story is a living thing. A story has the capacity, you know this, a story has the capacity to act in the world, to make things happen in the lives of the ones who tell the story and the lives of the ones who receive the story. The individual listeners, the public circulation of stories. And you know very well, I'm sure, how stories can virally travel. I was giving a talk just 2 days ago, and it came to me as I'm giving this talk that stories are flammable. Stories are flammable. They give heat and light. So, you know, the discovery of fire in our ancestors was like the pivotal event in what we now call human lives. If stories are flammable, they can also destroy. I mean, think of the stories that have changed your life. So these are things to be handled with great respect. Now, there's two things on the docket for this conference. One is the lives of stories, and the other is the stories of lives. Life stories, or the stories of lives, come from the teller. And it can be retrospective, it can be prospective or predictive. The teller can be an individual, it can be groups, it can be a family, it can be a neighborhood, it can be a political organization or an ideological group. We have to ask whose stories matter. Who gets to tell them or write them or have others pay attention to them? You know that there is such a thing as theft of stories or expropriation. And I got to say that my colleagues, I'm an internist, my colleagues in medicine have, some of them, been guilty of expropriating stories of their patients that they then tell completely on their own. Now, stories of lives are not the mirror image of the lives of stories. Both things go on at once. The stories of lives are the creative act of the imagination in whichever way the story is represented. I'm not assuming that all stories are built with words. In fact, we're going to be looking at images today and not words at all. And the lives of stories are forces in the world. Now, stories of health and illness are a special case. I think they're even more complicated than some of the other kinds of life stories or memoirs that we might read. The creative act is side by side with the physical body and mind. It is the case that bodies have stories of their own to tell. And I can find, if I'm in the office with a patient, I can find that the patient is talking to me in language and their body is talking to me like in the other ear with the language of the body, which is, how a person is sitting in the chair, or smells or sounds in that body. So the very telling and listening of stories of health require sensory acts and conceptual acts and cognitive acts and also bodily acts. So I think we are kind of a special case and need to pay particular attention to our lexicon. Now, I'm glad that the title of this talk is why narrative medicine matters. Narrative medicine, we first used the word in 2001. And I'd been working at Columbia with a group of colleagues that I had gathered really over the years from arts and sciences and from the clinical campus. So there were pediatricians and family physicians and patient advocates, nurses. There were English professors. There were cinema scholars. There was a psychoanalyst. There was a novelist. And we together, we found some money. We got some money from the NEH so that I could pay people to come teach one another from their disciplines. And this was over 2 years that we met 3-4 times a month, like 3 hours at a time, with many of the other colleagues and experts from the nation and international, to really drill down to say, why should creative works matter? What is it about the humanities and the arts and sort of qualitative social sciences that make a difference in the actual clinical delivery of healthcare? And can we ever make a case that creative work and the humanities and the arts improve the healthcare? So that was the task that we set ourselves to. And indeed, over the course of that time, we developed a strong conceptual model that we still use. We began back then, this was 2006 by then, giving narrative medicine workshops, getting persons from outside Columbia to come work with us, study with us. I published the first book in 2006, the narrative medicine book. And then we got a bigger grant from the NIH, and this was a 10-year grant, to bring this work into the curriculum of not just the medical school, but the health profession schools. So that's kind of the birth of this. It grew nationally. We had more and more publications. The books were translated into many languages. We continued to get means, funding or other means, to test the hypothesis that narrative work can improve the actual healthcare. Along the way, and I hope many of you have been involved in some of these things, we have now a Master of Science in Narrative Medicine program at Columbia, a certificate in narrative medicine. We have a Narrative Medicine International that includes people from all the continents. Lots of required curriculum at Columbia. Many other medical schools have at least elective courses or programs or involvement in some way. And we know, and it is so exciting to see that persons have been using the term narrative medicine to point to the kind of work that we're doing today in this conference, which is bringing the creative, imaginative, conceptual work from the arts directly into the care of patients, into the experience of patients, the experience of families. We're now a department. In 2018, Columbia started a Department of Medical Humanities and Ethics, and narrative medicine is one of the divisions. So I rather love the idea that, Columbia has a division of cardiology, a division of pulmonology, and a division of narrative medicine. This should give us all glee. We published a textbook in narrative medicine in 2017, calling it The Principles and Practice of Narrative Medicine. And it's already, it's been translated into not just French and Italian, but Chinese and Korean and Japanese and Polish and Greek. So we all should feel very, very proud of ourselves. Okay, I want to show you some pictures now. I want to invite you into my department. This is what you see. Can you see this? I hope you can see this. This is the image. This is the, it's a lithograph that faces you as you enter my suite. It's by Man Ray, who's better known as a photographer, but is also a printmaker. And I'm hoping that the chat is going to work, because what I'd love to hear really from those of you in the audience. Now, I don't want paragraphs. I don't want questions. What I want is words, like one or two. And I know that I'm with a group of writers. So I can even get away with saying, give me one or two words. So, what do you see in this yellow and white and gray and red image? It looks like there's either a sun at the top or a sunny side up egg. But I'm hoping that some of you will tell me what you see. Now, I should explain. As you enter this big suite, this is the very first thing you see, and it's big. It's like 3 or 4 feet high and 3 feet wide, 2 or 3, and in an ornate frame. And it really is. It's not just a print. It's one of the original lithographs that Man Ray made. What I'm seeing in the chat is I see a bird. And sure enough, in the middle, there's like a bird with a long beak and a wing outstretched. But I also see birds and a kiss. And indeed, if you can shift your eye the tiniest bit, you can see the bird in the middle sitting on a flower or something with leaves and a tail that looks a little bit maybe like a mermaid's tail or a fish tail. But then, and here's one that says sun, love, and hope. I love it. Freedom, healing. Somebody says, first I thought I saw a woman's face. Then I saw 2 people kissing. So if you shift your focus the tiniest bit, you can see the bird in the middle, and then boom, It turns into two pairs of lips, two noses touching. Do you see that? I hope everyone sees both. Lips, energy, love. I see a voluptuous naked female dancer. I love that. So do you see? Now, you don't know like who's talking exactly, but you do know that this group of us is talking. This group of us is talking. What we're talking about is, what do we see this as? And at the beginning, we were seeing this as a bird on a flower. And then we were seeing it as two people kissing. So seeing differently at the same time. Wittgenstein says, seeing as is not part of perception. And therefore it is like seeing, and again, not like seeing. And I think this is the kind of seeing that we're looking for in narrative medicine. It's like being able to see around the corner. It's being aware that one's own, whatever, perception, bias, assumption, impulse is not the only one. And that one looks around for other ways of seeing things. And that one respects other ways of seeing things. See, somebody says intimacy, transformation, and the revelation is indeed in having the capacity to see as more than one's own initial impulse. Now, we use this kind of seeing early in COVID. At the very beginning, in like March 2020, I said to my crew, the things that we know how to do are useful now. And I think we should do them on a big scale. Because at the very beginning, you remember, it was social isolation. It was fear. It was protection. It's what's going to happen to us. And so through that pandemic, we had these big public Zooms that brought together literally hundreds of people from all over the world for like 1 hour sessions where we would read a poem, look at an image, converse with whoever was on the Zoom, and then give people time to write about what they saw and also to read aloud what they saw. So we did this at the beginning once a week, and people who came got to know one another. And it became rather quickly a community of persons who would come to these Zooms. Eventually, we needed one in French and one in Italian and one in Polish and one in Greek, and we're still running that. We also were asked by many sections in the hospital to give private narrative medicine training. So we've been working with the palliative care service, with the general pediatricians, with the MICU, the medical intensive care unit staff, with the ophthalmologists of all people. We're starting now with the neurologists and residents in medicine and pediatrics. These are all groups who came to us to say, please, can you help us with your narrative work? Do you see? So all of the things like what Naomi and Mike were doing with you this morning, you know, how is kindness related to sorrow? This is part of what they wanted us to do for them. We have a group from the entire cancer center staff at an affiliated hospital, Lawrence Hospital. They have a staff of 60 people, and they contracted with us to give all 60 intensive narrative medicine training. The trainings were 6 sessions in a row, 8 or 10 people per group. They did really serious, heightened work in narrative medicine. We're just now finishing up the very end. So this is what we call attention. I want you to remember 3 words in all of what I'm saying. I want you to remember 3 words. And the first one is attention. And what that means simply is the capacity to perceive, to see as many things as one can, to absorb the news from what we witness, whether it's a patient in the office or a reporter on the nightly news, that we can watch and listen and judge and weigh and note our own responses, but put aside our own responses to really, really pay attention to what is being said. And our task is to sharpen this attention, to focus it. Simone Weil, the religious scholar, says the capacity to give one's attention to a sufferer is a very rare and difficult thing. It is almost a miracle. It is a miracle. And this is what we do in healthcare. Angelica, let's go to the next slide. If you come further into my suite, you find this photograph, which hangs in my office. It's multiple photos, as you see, overlaid. It's by Helen Sear, a contemporary photographer in Wales. And now we can chat some more about this. I want to know, what do you see here? It seems on the surface of it like, I don't know, I guess the back of the head of someone, doesn't it? You see a netting kind of dots over the slide. Helen Sear puts these on many of her photographs or photo montages, and she does it by hand with a digital pen on her screen. And it gives an effect of something being contained or held or unified in some way. But I'm curious to see what you make of what is she looking at? Do we know? And what is going on in her skull? Here, a young girl staring out into a field. Absolutely. We see over her shoulder that she's looking at some greenery. There may be a valley behind that. There may be a river. There may be the ocean. We don't know, but we certainly see her looking at greenery. And then someone says, there's a forest in her hair. And sure enough, it is as if what she's looking at becomes part of herself. A woman looking through a dim window, we don't know. It's very evocative. It's very intriguing, isn't it? To think about how to think about this image. Someone says yearning. Now that's gorgeous. And there's a desire. Maybe there's a lack. But there's a seeking some kind of maybe completion. Here's a very specific one. Older woman with hair in a bun staring into a valley, then see a forest instead of hair. Someone else, it looks like trees in her hair. Indeed. And then someone goes, look how someone else goes very abstract. A woman searching for peace. And finally, she seems to dissolve into the mountain range. So what you're all saying in a number of ways is that the relation between the self and the world is shifting. And maybe it's a loss of self. Maybe it's a gain of self. I bought it and I put it in my office because it reminds me that what we look at become part of ourselves. And if she's looking at a forest, it has to get metabolized. It has to get into her before she can actually know what it is. Someone says she seems more of a projection than a solid presence. Well, there you go. You know, in literary scholarship, in phenomenology, which are really the fields that we base narrative medicine on, narrative theory, we feel funny if we use the word self, because is there really such a thing as a self? Is there really such a thing as a identity? And because isn't it always shifting depending on what you're looking at or thinking about? So this image gives me a way to handle the idea that I may be a subject, and yet that which I perceive becomes part of the composition, literally, of my own body. And the fact that the forest ends up in her cerebellum, which is the bottom part of the brain, and not the cortex where the thinking goes on, means that the outer world is not only involved in what we think about, but is involved in things like controlling your heart rate, or controlling your temperature, or your respiration, all of those deeply, deeply organic parts of life. Angelica, let's see the next one. This is another back of a head. This is by Toyin Odutola, who is a Nigerian-American printmaker and photographer. This is a lithograph. And if I had another version of the lithograph, you'd see that it was put on blue paper and not the white paper that I got the original from. This is recent. This is 2012. I'll give the chats a few minutes to get going. But we see, again, the back of the head. We see different forms of light and dark. We see emphasis on some parts of this. It's not a profile. What would you call it? A back view? I don't know. There are particular lights, for example, on her pinna, the ear, the external ear. I hope you notice the earring. But the question is, what are the marks on her skin? Now, some are saying it looks like a ghost. I'm not sure if that's about the last one or the current one. It's a reflection of water against skin. Isn't that interesting? It's a person in motion. So you get a sense of this Odutola image that she's not static, that there's some and again, it would be great to have whole paragraphs from each one of you, but I want to let each of you see what the others have written. Okay, scars maybe, or pox. What could these lighter spots on the back mean? Scars maybe, or pox. Now, keep thinking along those lines. Both scars and pox are unwanted marks on the skin, are they not? Spots of light representing our history. Well, that's a very optimistic way to think about it, that these are milestones maybe in the history of this particular woman, or in the history of this particular woman's race or culture or country. Someone sees the shapes of the lights and the beautiful constellations of light on her skin. So this commentator is looking for the patterns on the back of the figure, looking for significance. Is it a Big Dipper? Is it Orion the Hunter? Is it it's a constellation, meaning individual spots of light become meaningful by virtue of their association. See? And then, like an X-ray, what lurks beneath the surface waiting to be revealed? What does this mean? What is this signal to us? Now, somebody said scars or pox. You could have said tattoos. You could have said whiplash. You could have said the result of beatings, of whippings. And certainly with our American past and our plantation past, that kind of comes to, sadly, comes to the mind. Here's what Odutola says about how she handles the skin. She says in an interview, Skin is the geography I travel in order to discover each individual and his or her story. With every line I mark up, I map out the territory of their realities. The territory of their realities. And here someone in the chat says, my first thought was the scars of an enslaved person. The territory of their realities. And now I'm going to tell you the name of the work, which I haven't told you yet. And it's the name of the work that made me choose to show it to you now. Here's the name. If she doesn't say anything, then it never happened. Is that chilling? If she doesn't say anything, then it never happened. Which, doesn't it give us such an obligation to tell? Doesn't it? Okay, we're going to go to the next few slides. I told you to remember the word attention. Now we're going to go to the next word, because we discovered a means to sharpen attention, and that is through representation. If we can represent what we're paying attention to, if we write it down, if we say it to someone else, if we draw it, if we paint it, then it becomes real. And if we don't represent it, it simply goes away. Now, here are some of the images that I used with my oncology staff at Lawrence. We see, okay, this is not a photograph. This is a watercolor. And this is not from the recent past. This is 1830, someplace between 1830 and 1845. It's a watercolor. What do we see? It could be abstract. It could be figural. It is moody. I think all of you might agree with me that it's moody. I'm going to tell you, it's by Turner, J.M.W. Turner. It's called Sea and Sky. So somebody says, I don't know what it means, but I'd like it in my house. That's great. Which means if we were to say, what do you mean, the person who just said that? Or maybe you can tell us. There's a mood of this piece that appeals to you. It might be serene or peaceful. It might be recollecting something. Someone says a beachfront. Someone says sunset on the water. There you go. That was before I told you sea and sky. Calm, sunset, calm. So this is kind of the ocean in one of its moods, isn't it? Sunrise at the beach. We don't know which one it is, sunrise or sunset. But I'm hearing a chorus of calmness, serenity, almost pacifying. There's a pacifying nature. We know the ocean, and we know that this is one of the moods of the ocean, but where's the storms? What about the shipwrecks? There's different aspects of ocean, aren't there? Let me show you another one. Angelica, let's go to the next one. This is a photograph of Hiroshi Sugimoto, 1991. And the name of it is The Sea of Marmara. Now, I hope the what do you call it? Resolution is high enough for you to see the texture of the surface of the sea. We're seeing a rather blank sky, unmarked, no clouds, no planes, no moon. We see a horizon that's dead center, which is unusual I'm sure there are some photographers and painters among us today, and you know that the horizon is usually like in the upper third or the lower third of a work, but typically not smack in the middle. So it's like drawing attention to itself as the horizontal horizon, right? Oh, here's a long one. This kind of picture can show movement of waves, and we can see the movement. Similar used as a backdrop for the play The Waves. Oh, I've never seen a play The Waves. The Virginia Woolf's novel is marvelous. I would love to see that. I saw it first in an exhibition at the Hirshhorn Museum in Washington. And the exhibit was called, now listen, the exhibit was called What Absence is Made of, right? And here someone says darkness, danger, something lurking under the surface. So we've got double duty here. There's a kind of Pacific looking ocean. There's a very straight horizon. There's a blank sky, but there's some maybe thing lurking under the surface. And if the exhibit says what absence is made of, it made me wonder. I didn't see absence. I saw rather fullness. I said, oh my gosh, it's the entire sea all in one. Look at this. Plenitude is one way to respond to this image. But then once I heard another response, I said, well, there is something kind of blank, isn't there? There is something kind of lacking. There's no landmarks. There's no boats. There's no, we can't even see the dolphins underneath. Someone says calm before storm, way, way out at sea. I was in Istanbul in 2018. This is after I had found this painting, this photograph. I'm in Istanbul, and I discovered there that half of the city of Istanbul is in Europe, and half of the city of Istanbul is in Asia. I didn't know this. And they took me, my host took me across the bridge to go from Europe to Asia while we were still in Istanbul. And I asked, what is this body of water we're crossing? It was the Sea of Marmara. So there's great significance in this particular sea, in this the connotation of this particular body of water, dividing continents, especially in these fraught times. One more image. This is not a photograph, it's a painting. It's a painting. It's by Vija Selminj, and it's called The Big Sea. And I show it to you just for a second. This is close up, close up. It's like a square inch of ocean. And I hope I can get a couple of comments, because again, sometimes it seems buoyant and you could just jump right in and that ocean would keep you up. And other ways to think about it are, this is one tiny square inch of the entire Atlantic, Pacific, Arctic, Indian, right? And it's one particular square inch of it, which reminds me now as a clinician that I might see one particular person with coronary artery disease, and I'm paying attention to that one particular person and not all the epidemiological factors of all the coronary artery disease. So it's the universal to the particular and back again. Somebody says it gives me motion sickness, or you might be on the surface of the moon. So let's turn the slides down. And I've talked to you about these two movements of narrative medicine. One is attention, and the other is representation. and that the representation is a way to build our own capacity for perceiving, for getting inside of that thing that we're looking at. Now, my oncology participants at Lawrence Hospital realized at the end of their training that they could see more in the world. They could see more in images, in poems, in stories, and certainly in the words of their patients. They came through the work they were doing with me and with other facilitators. Through the work we were doing, they came to know one another at a deeper level than they did before, because they were writing, they were reading aloud, they were responding as you have in our little chat. They experienced what we call the third movement of narrative medicine, which is affiliation. And whether that's with patients or students, the outcome of this kind of work is a cohesion. It can be team cohesion. It can be a decrease in burnout. It can be an increase in reward for the work because of the affiliation that takes place among colleagues, between teachers and students, from a nurse to her patients. It also increased, as we asked them at the end, it increased their own self-awareness, the mutual trust and respect that occurred in the cancer center. It increased their confidence in their own creative capacity. And the clinical setting showed an actual shift in practice, that they were able to do different things for their patients with cancer. So what I hope you're taking is how pluripotent and how multidimensional is this work. You know, it used to be that we made a difference between science and art. Well, that's science and this is art. And in medical settings, the art was usually just the recess and the science was the thing itself. Well, we're starting to know, and it's through this work, that both scientists and artists are using the same methods. We're using methods of epistemology, which is how do we know what we think we know? We're using aesthetic methods of seeing and taking in and interpreting and establishing meaning to appearances. And finally, we're telling one another what we see. We know, we see, and we tell. So that this conference is paying attention to the telling, because without the telling, anything that is seen or observed or appreciated is simply locked inside the one deracinated, lonely person. Whereas with the telling, with the representing, with the sharing, we find ourselves in a shared world. Angelica, let's go to the word slide. I have one slide that has words on it, and I will read it to you. John Banville is a novelist. The Infinities is a novel written about the gods on Mount Olympus. And these words are spoken by Zeus, who's the head god. And the other gods on Mount Olympus, which is, you know, the whole Greek, the whole Greek god group, the other gods are laughing at us humans. They're saying, look at them down on earth. They're like always getting into trouble. Zeus says, this is the mortal world. It is a world where nothing is lost, where all is accounted for, while yet the mystery of things is preserved. He tells about the failing evenings of the self, solitary and at the same time together, somehow, here in this place, dying as they may be, and yet fixed forever in a luminous, unending instant. So I end with my luminous, unending instant. Bring that with you. Attend, represent, affiliate, and revel in your creativity. Thank you all Thank you very much for giving me the chance to meet with you.
Thank you so much, Rita. That was just wonderful. I saw those images and I had no idea what you were going to do with them, but that was awesome. Thank you.
Okay.
Everyone, you now get to take a little break. We will come back at 2 o'clock with a very exciting panel of Philadelphia area nurses who have amazing stories to tell about their experiences through the pandemic, before the pandemic, after the pandemic, just great stories to tell that I think will go a long way toward Rita's themes of attention, representation, and affiliation. So thank you, and we will see you at 2 o'clock.
You have the power to stop this virus.
By being fully vaccinated, you are not only protecting yourself, but also those who are unable to get the vaccine,
such as children under the age of 12.
Our greatest tool to beat COVID-19 and its variants is in your hands, Philadelphia.
And we're counting on you to use it.
Juntos hay que proteger nuestra comunidad y vacunarnos hoy.
Together we will beat COVID-19.
Hi, everyone. Thank you for joining us. My name is Kelly O'Shea. I'm the Deputy Health and Science Editor here at the Inquirer. And today I'm going to be moderating our discussion with 3 Philadelphia nurses who are here to share their experiences working through the pandemic and telling their stories with the public. Before we get started, I want everyone to know that we'll reserve the last 10 minutes or so for questions from the audience. So if you have a question or comment that you want to ask the panel, please submit them in the comments section at the bottom of this page, and we'll get to them at the end. So let me just introduce our panel today. Carla LeCoyne has 33 years of experience as a maternal health nurse at Einstein Medical Center in North Philadelphia. She's also the Political and Community Outreach Chair for Einstein Nurses United. Hi, Carla. Maureen May is a nurse in the Infant Intensive Care Unit at Temple University Hospital with 35 years of bedside experience. She's also the president of the Pennsylvania Association of Staff Nurses and Allied Professionals, which is the largest nurses union in the state. Hi, Maureen.
Hello.
And last, we have Tiffany Montgomery. She is an assistant professor of nursing at Temple University's College of Public Health. She also worked as a per diem labor and delivery nurse at Einstein, but burned out from COVID. She resigned from clinical practice last winter. Hi, Tiffany.
Hey.
How are you guys?
Good. Hi. We're well.
Okay, so before we jump into specific questions, I know the audience really wants to hear from all of you, and I want to give you some time to tell us what you've seen and experienced over the last 20 months. Tiffany, your path in the last year has probably been the most unique, so why don't you kick us off?
Sure. So, wow, it's crazy being back here because this time last year, I was here as a participant. I participated in a story slam and loved it and ended up writing an op-ed for the Inquirer that was published in December of last year. Yeah. And since then, a lot has changed. I've gone from being a postdoctoral fellow at Drexel University and working per diem at Einstein in labor and delivery to now being an assistant professor on the tenure track at Temple in the College of Public Health. And I'm no longer in clinical practice. Well, that's not true. I'm no longer in traditional clinical practice. I'm doing some things on the side on my own, in my own practice, but not at the bedside. And I got tired. It got to be really hard, especially around the holidays, because I had to cancel a trip. My godchildren were coming out to visit me. I'm from California. And they were coming to visit, and my goddaughter, who's now in 11th grade, was going to stay for a week, and we were going to go up and down the East Coast and look at some colleges and do things like that. But when the pandemic when we noticed that it wasn't going away and the numbers started kicking up again, the cases started increasing, I said, hey, guys, don't come out here. So, we canceled that trip. And that was really hard. And then for Thanksgiving, I decided not to go anywhere because I was still working in clinical practice. I had patients who were COVID positive. I had some patients who were really sick and they were being transported back and forth between labor and delivery and the ICU. And I didn't want the guilt of exposing somebody that I love to COVID. So from October through about January, I stayed inside. I did not go outside except to go to work at the hospital. I was able to do my job as a postdoc, virtually. So that was okay. I had everything delivered. I didn't go to a grocery store. I didn't go out to eat. I didn't go anywhere. And I was just sort of a hermit in my house. And Christmas was the hardest time because it was the first Christmas in my life that I spent away from my mother. And it was not by choice. There's only one other Christmas that I spent away from my mom. And that was because I was in college and, thought I was grown and I don't need to go home for Christmas. And I hated it. I said, I will never do that again. And so I spent every single Christmas of my life with my mother. and knowing that I could not go home and it was of no fault of my own, that was a lot to deal with. And I said, I cannot continue to just put myself at risk like this and then unintentionally expose my friends and family. The thing that really caused me to leave the hospital, because I was planning, I knew that I would be starting at Temple. And so I was planning to work clinically through the summer and until I started at Temple this year. But we had a staff meeting. And in that staff meeting, one of the administrators made it a point to degrade and demoralize me in particular when I brought up an issue of staffing and said, hey, we cannot do what the physicians are asking us to do because we just don't have the numbers. We can't do it. So stop bringing inductions in here when they really don't need to be here. And she said, we're not going to talk about staffing in this meeting. And I said, we can't not talk about staffing because we need staff on hand to take care of the patients who are here. And she yelled at me and she said some things to me that I did not take lightly. And I said, oh no, why am I doing this? This is a per diem job. I don't need this job. So she gonna talk to me crazy. I can't go home and visit my mama. I have told my godchildren that they can't come visit me. I'm not even going to the store because I don't want to accidentally expose somebody to something that could kill them. And you talk to me like I'm crazy. I submitted my letter of resignation and I have not been back. My last shift was on Christmas Day.
Wow. Yeah, that is actually a topic that I want to get into a little bit more, that feeling of being underappreciated, because I think you've all touched on that. But let me let Maureen go next and share the experience that she's had.
Hi, Tiffany. I'm curious to know who that administrator was.
I will tell you offline.
I know you will. I know you. I'm not surprised, though. But again, thanks for having us here. It is important to tell our stories. And I am going to say, from my own personal experience, we talk about what we experienced individually. I experienced, the first was a feeling of fear. It was a fear of the unknown. We didn't even know what was coming our way. We saw the media, we saw it happening in other places, but we didn't realize how devastating it was going to be. So we had that fear, and it was just of the unknown. I did have within myself the faith to want to do the work, and I knew that I would do whatever we needed to do. That's just what nurses do. They step up to the plate. The other piece of it was the confusion, and I'm sure that Carla and Tiffany can share this with you also, is that we were very confused. We had so many ever-changing policies. Every day you would walk in and it would be a new policy. And the expectation was to lessen our standards of care. So that's where confusion came in, and I felt a little bit angry around it, but we were lessening standards of care around infectious disease prevention practices that we hold so very strongly, as proper care. So, that was a part of it. It's like we're supposed to forget about all the longstanding infectious disease prevention practices. Now we're just supposed to go with what we're told to do at this point. So that was there was confusion and anger and frustration around that, but we still were doing what we needed to do. And each time we learned about a colleague or even a PASNAP member or a family or a friend that contracted COVID, the first thing you wanted to know is, are they going to be okay? Because we're nurses, we're nurturers. We wanted to make sure that in our heart that they got the care they needed and if they were going to be okay. Again, that was that unknown. But and will they make it? What's the impact? And the impact for me was I did have family and they did survive, but we also had colleagues that didn't survive. And it was just the unknown. But I also experienced dehumanization of care. And I work, and Tiffany, if you worked at Temple, we're a baby-friendly hospital. We have baby-friendly designation. And one of the basic tenets of that is that we do not separate the mother from the baby. When they had COVID, we separated them immediately. And then we had these practices, the visiting practices, where mom could only come once a day. And I work in the infant intensive care unit. So working there, you had mom coming in once a day. If she was hospitalized, she could come more. But coming from the outside was a no-no. And if you came in, you had to stay there all day. And once a day was your option. And you weren't visiting at night. So working in a baby-friendly hospital, we were not baby-friendly. Moms were wearing masks, with gowns, gloves, shields to take care of their baby. So we experienced the dehumanization of care. I'm going to say that it was already there when it comes to staffing and computers. It's already dehumanized. This only really made it worse. So, and coming here today and being able to speak to you and to the group here is an opportunity for us to share these stories and, just to let you know that nurses are mind, body, and spirit clinicians. That's what we are. And having this opportunity has shed the light on what is wrong with the healthcare system, which we already know. We work in it. As nurses and union nurses, we fight for staffing. We were fighting for staffing long before, but then we ended up fighting for PPE. So this is a great opportunity through the media to be able to share our stories. And we did go through a lot. And we did, every one of us knows that care is being dehumanized. And it wasn't just COVID that did that. It was long before, and we still are feeling that now. So again, for me, the public doesn't know or understand how stunningly difficult care is and how complicated care is that a nurse delivers and what we provide. So, and I also have to point out the public does know that we're important because for 19 years, we have ranked #1 as ethical and honest. So having this opportunity to share that fact, which most people know, 90% of polled people say, in the Gallup poll say that we're the most trusted, we're the most ethical, and for us to come and speak to our experiences is a great opportunity. I'm still working in infant intensive care unit. I love what I do, and thank you again for this opportunity.
Thank you, Maureen. Carla, why don't you tell us about your experience?
First of all, thank you for having such an amazing panel of women that were able to show a part of the pandemic that deals with mothers and babies and how that looks. There were so many stories that showed the ICUs and everything like that, which was awesome. But as the women, just discussed, Maureen and Tiffany, it's that beginning. It's the point where women are bringing children into the world, and this is like something that brings families together. It was so hard. It was so hard during a time where, as Maureen said, we didn't know what was happening. We didn't know how to, make sure and tell these moms and educate these moms that everything was going to be okay. We didn't know. And to have a situation where I work mother-baby, so I deal with undelivered moms, delivered moms, high-risk pregnancies, lactation consultant. I couldn't tell my high-risk moms whether or not their unborn child was going to be okay. I couldn't tell the moms that just had their babies, who the moms are COVID positive, if everything was going to be okay. And it was just, I could only hold their hands and do the best to support them. And how does one truly support woman to woman when you're wearing a mask, when you're wearing gloves? And it's just so hard. And as Maureen was saying, not only were we trying to protect patients, we were trying to protect ourselves. We were being told that we could use gowns over and over again, and I knew that was wrong. I knew that was so wrong. And it was one of those things that I felt like they wanted us to give everything that we had, but they weren't willing to give us what we needed. I feel like hospitals would rest on laurels of being magnet, and that was a huge thing for them. And I believe we discussed it before that magnet sometimes is something that administrators can discuss at a cocktail party. My patients that I love that look like me, Black and brown patients from humble beginnings, they want to see someone who looks like them, who can care for them, and that they trust. Magnet does not matter to them, and I didn't need a magnet designation. I knew that I was a magnet nurse, and all the nurses that showed up every day that they could, they were magnet nurses already before this whole credential came to us. So it was really tough. It was really tough. I believe it brought us together as nurses. The few times, as Tiffany would say, the few times that you would go out, sometimes I would go to a Target in Abington, and I would see the other, Abington nurses, and we're all dragging, and you would just look at each other and just give each other a look like, you okay? Okay. We're going to go home, take a shower, and do this again. So it was an honor. It was traumatic at times. It was a bonding moment. In my 33 years, I've never experienced anything like this. I don't want to ever experience anything like this. And I want to take lessons that I've learned as a practitioner and as a woman, and hopefully take all that knowledge and wisdom and make sure that the public knows and educate them, and make sure management, who they were lucky enough to make some of these decisions from the comfort and safety of their homes, let them know that this will not go away. Nurses aren't going away. We've learned to stand up. We've learned to, let our voice ring out, and we will continue to do so. So watch out. We're coming, and we're going to continue to come.
I love that. You guys all have touched on some topics that I really want to dig into here. And one of the things that you've mentioned here, and also in some op-eds that you've written for the Inquirer and other media outlets, was the feeling of being underappreciated by management. I want to talk a little bit about the repercussions in your field of that lack of investment in nurses from your institutions. I mean, Tiffany, I'm sure you're not the only one who has left the field at this point.
No. And it's interesting because I think the public's perception is that if you have an RN license, you work in a hospital and you take care of inpatients. That is not true. Only 50% of nurses work in an inpatient setting. Nurses work in legal offices. Nurses work in public health facilities. Nurses work in educational facilities. Nurses work in prisons and jails. Nurses work all over the place. A lot of us work from home, right? The pandemic forced us to get creative about the things that we do, like I did. And I said, I'm leaving traditional bedside practice, but I'm not done taking care of my, as I call them, pregos, my pregnant ladies. So I started a perinatal concierge business. I still take care of pregnant women. I just don't do it in a hospital. And so, we can get creative, and we have options. And that's what it's important for folks to realize. We don't have to stay at the bedside. A lot of us will start our careers at the bedside, but many of us leave for various reasons. And I think that living through this time has shown a lot of nurses that we don't have to continue to deal with poor staffing. We don't have to continue to be talked down to. I worked through most of the pandemic, and I've never had a COVID test. And the reason why is because my hospital said, we don't care if you're positive, you have to come into work unless you're symptomatic. And so I said, well, what's the point of getting a test if I have to come into work anyway? So I've never had a COVID test. Wow. By the time I stopped working at the hospital and would have started getting tested, I got the vaccine. And so I didn't need one. And, things like that, feeling like we are undervalued as human beings, was just really hard to deal with. There was a point in my work where we stopped using PPE appropriately. And that was something that we already knew that was happening. And then we went from, wearing one N95 mask all day long. God forbid the strap break on it, you're going to have to go to somebody's office and ask, can you get another one? So we went from that to now you can take care of COVID and non-COVID patients on the same shift. Excuse me? So you want me to take care of a patient in isolation at the same time that I'm taking care of a healthy mom who is laboring and getting ready to deliver a baby? This is not okay. This is not okay. And, I feel like as nurses, we've already known that even though the public loves us and trusts us, we're kind of at the bottom of the totem pole as it relates to other healthcare providers. This just showed me that's true. And, you know, where there were physicians who would not come into rooms because they didn't need to, or would only come in when they really, really, really felt like they need to lay eyes on a patient. I'm in here pushing with her for 3 hours. And I'm very, very close to her. We are not 6 feet apart. And if she's pushing a human being out, I'm not going to tell her that she needs to keep a mask on her face while she's trying to push a human being out. You know, like there was a lot of issues, and I felt like the regulations were coming left and right, and people were forgetting that we are human beings having a shared human experience, and we needed to be valued and treated as such.
Yeah. Maureen, you mentioned in one of your op-eds that nurses were feeling like they just kind of had to keep taking it on the chin.
It's true. We did. And we did keep taking it on the chin. Most of us that are in direct care, I've been in 37 years at the bedside, and I have to say I love being a direct caregiver. I love being in an acute care facility taking care of patients. So that's number one. But we did take it on the chin. We take it on the chin all the time. So we were taking it on the chin even more. And part of the reason why we are underappreciated is that we have competing values. As nurses, we're not looking at the bottom line. Our bottom line is our patient. So we don't look at them as a number or a diagnosis. We put that all together, mind, body, and spirit again. We put that all together. And we've always been underappreciated by management. But the budgetary limits that they have, or whatever their constraints are, it trickles down to the bedside and to us. So, you know, how do we correct that? It starts by we value ourselves. The public values us. We love what we do, and we value one another. Nurses value one another. If anybody got us through this pandemic, it wasn't the fact that they hooked us up to a link where we can talk to somebody about our PTSD or our challenges or our sadness or whatever we were going through. We got through this pandemic with one another. Yeah. So we are undervalued. Management can give you all the tools they want online to figure out how to feel valued. But ultimately, we value one another, and we value the care that we give, and we believe in one another. Nurses pretty much believe in one another. So yes. And what else helped us to value what we do is our union. So PASNAP is a very strong nurses union with other healthcare providers there. And we have that union support system too. And we were able to get to tell the public that we're taking it on the chin even more. Right. But that was because there was the union connection, and there was that you came to us and said, hey, what's going on? And so with all that, you know, even though we are being underappreciated, we appreciate one another. We really, really do.
That's great. One of the other, you know, I think you kind of touched on this a couple of times now, this dehumanization of care throughout the pandemic. I know telemedicine is part of that. I'm kind of wondering how the stories that you've told with each other or with the general public have helped you feel like you can reconnect with patients or colleagues who you were losing that connection with over the last year.
Can I answer?
Sure.
I feel as if supporting one another and just being able to hear a nurse say what's going on and have other nurses say, it's not just me. It's not just me. Another healthcare provider feels the same way. And just like Marlene was saying, how we're support for one another. It's an amazing thing that when you're in the trenches with someone, it's no longer a situation where it's, you know, delivery room versus mother baby, NICU versus the nursery nurses. It's like, oh, okay, ladies and gentlemen, we're all going to get in this together, and we're going to do this together. And just the fact how, you know, I found nurses were using social media, whether it's Facebook and Instagram and Twitter, and they were becoming like these amazing, like guerrilla style, like documentarians. And they were saying what was going on, and you could kind of like check in and see what's going on with this person, what's going on with this person. And even though we weren't next to each other and we were way more than 6 feet apart, it still brought us all together, nurses in other states. And there were different Facebook groups that nurses would say, this is going on in my hospital in this state. What's going on in your area? And it was really, really awesome. It was just really awesome that we could take something so hurtful as the treatment that we were getting, and we could turn it into a positive thing. And listening to what Tiffany was saying about the COVID test, it is just crazy how hospitals were treating us with being tested. And to kind of segue to one of my stars that I absolutely love, Dr. Ayla. I am a huge fan of hers. I'm so excited. I can't wait to watch her later. I would just go around to other nurses and to patients as well, for their family members, and I would just like write down pieces of paper. This is Dr. Ayla. This is Black doctors. You know, go here. This is where they're going to be. They're going to be at churches. She was with Enon, which is my church home for a long time, Deliverance. And it's just, I don't know if she realizes how many nurses have been fighting with her, even though she never met us. Because there's so many Black and brown and humble, mean patients and families that had no idea where to go, who thought they were forgotten. And nurses are still, we're at the bedside. We're just showing people where to get tested. We're helping each other where to get tested. We kind of rock. We kind of rock.
I agree. One of the things that I wanted to hear from all of you, but Maureen and Carla, in an op-ed package for the Inquirer, you both shed light on problems of low morale and decreasing staff. And what I loved in that package was that you were literally calling on hospital leadership to address and fix these issues. I was wondering if that led to any kind of response that you got from that.
From the hospital administrators, zero. I didn't hear anything from hospital administrators directly or indirectly. They know it's out there. It was a beautiful article. I just have to highlight too. So about a week later, the nurses from PASNAP went to Harrisburg to lobby for the Patient Safety Act, which is about having safe patient limits. And so when we went there, obviously we had politicians that were there to speak. And Senator Collette, she is the sponsor of the Senate bill. And the first thing she said once she got to speak was, and by the way, that op-ed article was great. So we know it's out there. I know the administrators saw it. I know many of my colleagues saw it. And it was so well done. It was so real. So I know that they saw it. I don't know what, for us, it's just a stepping stone into putting us out there. Yeah. And for the public to know. The public doesn't know. They don't know. And when you have someone as young as Claire that was on that article saying, I'm getting my doctorate and I'm almost done with direct care, it's kind of sad. I've been 37 years in direct care. Yeah. What does that say? So, the hospital administrators, just the whole health system has to change somehow. And I believe that the groundswell will be nurses that helps make that change.
Absolutely. You mentioned the Patient Safety Act, and that reminds me, not patients, but for you guys, I mean, one of the unfortunate side effects of the pandemic has been an increased violence in your workplace. Can you guys tell me a little bit about that?
Can I take this, Maureen?
Absolutely.
Yes. I feel like there has been an uptick of support for nurses, but I feel like also with people not being able to get mental health support, people having challenges with mental health that have been exacerbated by being quarantined and things like that, there's been acting out. And sometimes we're there and nurses and healthcare workers get the brunt of it. And I was discussing the fact that I will be there for you. I will hold your hand. I will not take lunch. And I will do all those things and give you all I have to give, but you are not allowed to hit and act out on my body and my person. There is hurtful words. Hurting a healthcare worker is not okay. It is not okay. It is not because you're sick and because you're this. No, we need boundaries. And for me, that is a strong boundary. You keep your hands to yourself. I use my hands to help and to heal, and you shall not use yours to hurt me or any of my coworkers. So that's another thing that we're working on. We went from PPE and getting more respect and everything like that to trying to make sure that management realizes even if they don't honor our person, we honor each other. And whether it's a code gray, that someone's being hurt or brutalized and we go to support, somehow we will take care of each other, and we will also come together with other supportive organizations to come to management if possible to say this is serious.
Maureen, is there anything you want to add?
Yes, and I'll just highlight what Carla said. We definitely are working on that as a union. It is not okay to hit. It's not okay to punch. It's not okay to even squeeze anything that happens. It happens all the time. And in the past, it's been accepted. It's been an accepted practice. And we've been re-victimized by saying, well, how could you have done that better or de-escalated the patient? Bottom line is, I have to take care of the patients. There has to be additional opportunities and teaching. And we do have a liaison right now in the DA's office to help us work through the workplace violence incidences. They happen all the time. We're working on legislation with that. It starts from within, and it's up to us to hold our administrators accountable. And we're doing that. As a union, we're doing that. As nurses, we're doing that. But yes, staffing and workplace violence are our top two issues at PASNAP, and it's worsened. And Carla highlighted the fact that people are angry. We have a more violent society. When somebody comes into the emergency room, they go to the OR, then they end up in the floor. That all trickles down to the nurse. Everything is about the nurse. So yes, she's absolutely right. And we have a plan as usual. We try to work very diligently on making it better. Thank you, Carla, for your comments.
I want to talk a little bit about something that you brought up, Maureen, that nurses are among the most trusted profession. I'm sure you all, especially working with expectant mothers in a crazy time, we're getting asked constant questions. They're like, am I safe? Can I do this? Can I do that? How do you deal with that pressure?
I'll answer this. I don't think that it's pressure. I'm actually glad to answer those questions. I feel like for far too long, we've seen, even on news outlets and anywhere you go, anytime we're talking about healthcare, folks are talking to physicians. Well, physicians are not the only healthcare providers that can give educated and honest answers about healthcare and about health. Nurses take the same anatomy and physiology classes. We take the same chemistry classes that our physician colleagues take. We just decide not to go to medical school. We go to nursing school. And so we can answer those questions just fine. What I found during the pandemic, especially at the beginning of it, this time last year, I was doing a lot of talking to people's friends and families. I'm pretty active on Twitter. At the time, I wasn't active on Facebook or Instagram. I had closed those accounts down, but people would reach out to me on Twitter and say, hey, my brother, mother, cousin, whoever isn't listening to me, would you talk to them? And myself and a colleague from the National Clinician Scholars Program, we got together and had a literal presentation with a PowerPoint slide and everything that we gave to one specific family. And after that, I did it a couple more times without the PowerPoint. But we would get together and talk to people and say, hey, we're licensed nurses. She's a nurse practitioner. Let's talk about it. What do you guys want to hear? How can we answer your questions? The one thing that I found very interesting was when I would do this on social media, the trolls would come out. Mm-hmm. Now, I've been a nurse for 16 years. I'm a little bit younger probably than Carla and Maureen, and I don't mind going toe-to-toe with you. So if you want to talk foolishness and try to spread lies and untruths, bring it, because we can do that. I have a PhD. I'm very well versed in finding primary sources and throwing them in your face. So if you want to do that, we can do it. And I found that when people would come out and try to say disparaging things about me because of the information I was presenting, I would just hand them back information straight from the CDC, straight from the NIH or wherever else, primary sources, and say, this is what the science says. What you're saying is anecdotal. I appreciate your experience, but this is not how science works. This is not how we do things in this country based on one-off experience of somebody's second uncle on their third side. You know what I mean? And so having these conversations was very helpful. And I've encouraged other nurses, don't shy away from these conversations. When people spread things that are not true, or when people come to you and ask you to give them truths because they're scared, they don't understand, they just want to know more, it's okay to talk to them. And I've also been very vocal about saying, hey guys, we got it wrong. I'm a public health nurse licensed in the state of California. We mishandled our narrative and the messaging around COVID, and particularly the COVID vaccine, especially in Black and Brown communities. What people were hearing was that if you get the COVID vaccine, you won't get COVID. That's not true. The truth is, if you get the COVID vaccine, you probably won't die. You might still catch COVID. You might even end up in the hospital, but your chances of having long COVID, of dying from COVID, if you're vaccinated, are significantly decreased. That's not what we were telling people. And so they did not trust us. They were thinking we were lying to them. We're not lying. The messaging was improper. Let me tell you what the truth is. Let me show you the statistics. Let me teach you how to read this table. And then you can see the stats for yourself. And then let's talk about it.
Carly, you looked like you wanted to jump in there.
I actually, what Tiffany's saying is amazing and so true. And to be honest, initially I did shy away from giving and sharing my wisdom and educating our moms that were worried about their newborns. So I really need to take this back and unpack it myself. It's such a huge honor and responsibility when it's not just the mom herself, it's her and her newborn and possibly her little nuggets at home. And once I felt better, I realized some of the things that Dr. Ayla was saying is that some of our Black and Brown communities want to see and receive education from people who look like them. And I need to take this mantle up. It was a little uncomfortable. Take it up with pride. Listen to the stories. Yes, everything that you've heard about the Tuskegee experiment, it's true. It's part of the history, but let's also look at some of what's going on now. And yes, you did hear something different last week. We're learning, and I'm going to educate you as I'm learning. And once I understood to take up that mantle, it was like, okay, these women are coming to me, and I need to really come back with them with what they need. And it was an amazing experience once I was able to unpack that and do that.
Yeah, that's great. Maureen, you had mentioned in a conversation that nurses have gotten more media coverage during the pandemic than they have in your 37-year career. I want to hear a little bit about why you think that is, and also how you feel like you can build on this moment to hopefully enact some change moving forward.
Well, we did get some coverage when we were on strike in 2010, but we had a 28-day strike at Temple, which was awesome. I loved it. And the media coverage, well, I never expected. But when we got the coverage through COVID, it was everywhere. And it really allowed us to express what was happening on the inside. As I said to you before, I believe it's curiosity. People have that curiosity and they want to know. Crisis curiosity is what I called it. And so to have the media come to us and want to know those stories was really, really important. And we had constant calls and lots of the media outlets calling us and wanting us to speak to them. Also, we had a strike also at St. Mary's, and we did get a lot of media coverage then. So it's always about crisis, and COVID was something that none of us knew, and we were learning. So we were learning with the media. The one thing I have to say is that article that happened in I guess it's the health section of the Inquirer on that Sunday. We should have one every Sunday. My tip to you would be have a nurse's corner. I was thinking about that. Why not?
We would love that.
Have it. You will get a story every single week. Or if you can only do it, I don't know what your editors want to do, but you will get an amazing story. There's many, many nurses that want to tell their stories. And if you have a nurse's corner in the Inquirer, in the Sunday paper, however you do that, that would be amazing for us as nurses. It'll help escalate what's happening, highlight what's going on inside, and it'll really tell the real stories inside our heart of what's going on. And here, the nurses are honest, they're ethical, and they're professional, and they'll give you that view on what was it, Nurses Corner in the Sunday Inquirer.
Love it. We're gonna have to talk offline. I see 3 people who can write for us the first time. We only have a couple of minutes left, and we have a great question from the audience that I want to end with, but just one more that I am curious about. You know, telling these stories takes a lot of courage, and I know, Carla, in conversation you had mentioned that you're actually like a really private person, and I want to hear how all of you kind of overcame that and were like, no, what was it that helped you speak out?
I can just share just a little bit of what we were discussing. That I'm very quiet, very private, but I feel like when you're fighting for someone else, somehow it gave me more courage to get out there and to say something. And as I was discussing before, it took me like a half a century. I was 50 when I actually started saying more and doing more. And then once I realized, wait a second, I need to put on my own mask my oxygen mask before I help someone out. So I moved from being an advocate for patients, being an advocate for nurses, because if we're taking care of ourselves, we can take care of others. So that's what helped me, definitely.
Mm-hmm. I would say for me, it was my faith. I had to get really, really strong in my faith, down to the core of my faith, because somebody mentioned before, when the pandemic first started, it was scary. Like, there was a lot of fear associated with going to work for me. I remember days that I just broke down and cried and said, I don't want to do this. I could die, you know? And so it was my faith in just knowing that Einstein Medical Center, Philadelphia was my employer. They are not my sustainer. My resources come from heaven, not from them. So if I lost my job, I would still be all right, you know, and I just have a very fearless attitude at this point. I'm not afraid.
That's great. Mm-hmm. So this last question is from the audience, and I'd love for each of you to answer it. Someone asked, in what ways have you found that telling your stories, whether writing or just sharing them out loud, have helped you process the last 20 months? Maureen, why don't you kick us off?
I've always loved to tell the story of a nurse and direct care. And how does that help? It helps, as I said previously, telling our stories helps us to understand one another. And we have a lot of PTSD and moral distress happening now. So how has that helped us? It has helped me to be able to communicate with other nurses. We have each other. It helps to heal. Being able to tell your story is healing. It's a way of patient advocacy, because that's what we do. We nurture mind, body, spirit. There we go again. We're nurturing each other. So that's how it has helped me. And I hope that that's how it has helped other nurses, being able to express yourself and to tell your story. You know, people that have already been through war, combat, or any type of similar situation. That's how they heal, because we understand one another. And to be able to share that with the public is even better. So I believe that is what we have received, and the blessings from having the media shine the light on what nurses are doing and the pandemic. So thank you for that.
Great. Tiffany, how about you?
Yeah, for me, it's been a point of advocating not for patients necessarily, but for other nurses. There's a lot that nurses go through that people just don't know about. I mean, we learn to hold our bladders for 12 hours because a lot of times we don't get a break. There are things that we don't get. And I think that if people knew about this, things would change. Unfortunately, we live in a country where we don't do the right thing simply because they're right. We do the right thing because we're regulated to do so. And so if that means I have to go to Harrisburg and get some laws and some regulations on the books that will protect nurses, then so be it. But it won't happen unless our stories are out there. And so for me, it was, let's get the story out so that I can advocate for myself and my colleagues.
That's great. And Carla, how about you?
Just as Maureen was saying, it's so cathartic to get it out. It's almost like a journaling. But the great thing about this journal, it wasn't a private thing that I didn't want anyone to see. I wanted other nurses to see. And once again, to have that sense of bonding and to know that it's okay. And just like Tiffany was saying, sometimes you're in your car in the garage and you're just like, I don't want to go. And to see another nurse, or, you know, you're about to leave and another nurse is like, you coming back tonight? Yeah, I'll bring, I'll bring some coffee, I'll bring tea, we'll meet back here again, same bad time, same bad channel. And you just kind of laugh and just kind of do it, and we support one another. And if we're healthier, then we can be healthier advocates. But as Tiffany said, and Maureen will say, we are not shrinking violets. Don't think just because we are nurses that we are just meek and mild. We will fight for you, but we will also fight for ourselves.
That's right.
That's the perfect ending. We are right at 45 minutes. Thank you all so much. I'm excited about this Nurses Corner now. I'm going to hold you to that, Maureen.
I'm going to hold you to that.
Okay, great.
That would be amazing. Thank you so much.
Thank you all three of you. This was so powerful, and I really appreciate you sharing your stories with us today.
Thank you.
Bye.
So thank you, everyone. We'll reconvene at 3 o'clock for an interview with Sandro Galea, the Dean of Boston University School of Public Health, where we'll talk about his new book, The Contagion, next time. Thanks, everyone.
You have the power to stop this virus.
By being fully vaccinated, you are not only protecting yourself, but also those who are unable to get the vaccine,
such as children under the age of 12.
Our greatest tool to beat COVID-19 and its variants is in your hands, Philadelphia.
And we're counting on you to use it.
Juntos hay que proteger nuestra comunidad y vacunarnos hoy.
Together we will beat COVID-19.
Hi, I'm Dr. Ritika Kumar. On behalf of everyone at Independence Blue Cross, I'm thrilled to welcome you to this afternoon session. We're proud to help provide free access so you can explore the power of storytelling related to your health. Words have power, and when it comes to your health, your words are critical. This is true whether you are sharing your health needs with a caregiver, giving voice to a loved one, or helping to keep someone well as a member of the medical community. The past 20 months have reminded us how important it is to be accurate and compassionate with our words. At Independence, we have worked to empower our community with the knowledge you need to keep yourselves and your loved ones safe. Since the early days of the pandemic, our Beat COVID-19 campaign has continually evolved from stay-at-home measures to vaccine education. For us, effectively communicating about COVID-19 meant partnering with trusted local community leaders. We continue that effort today as we join our friends at the Philadelphia Inquirer in offering you the opportunity to elevate your own health stories. Now, if you have not heard Dr. Sandro Galea speak, prepare to be wowed. Dr. Galea is Dean of Boston University's School of Public Health. He has done some amazing work around population health management and the impact of social determinants of health on our health as a nation and a society. And we share Dr. Galea's focus on creating a more equitable society and health system. I have learned so much from hearing Dr. Galea talk, and I have no doubt you will leave this session feeling the same. Please enjoy the event.
Hello, Dr. Galea, welcome.
Good afternoon. Thank you for being here. Thank you for having me.
Everybody, just to remind you, I'm Charlotte Sutton. I'm the health editor at the Philadelphia Inquirer. And I am so thrilled that Dr. Sandro Galea is with us this afternoon because on top of everything else he's done in his very illustrious career, he is the author of the newly released book, The Contagion Next Time. I don't think you can probably see it very well on my monitor here, but it is a wonderful book. Despite the scary sounding title, it's really a very hopeful look at where we could be headed if we work very, very hard to get there. So, Dr. Galea, I just wanted to start out by hearing a little bit about your own health story. You are an immigrant twice over. Can you tell us a little bit about your background and how it's helped to shape your views on social justice and health?
Yeah, thank you. So I am an immigrant twice over, which is probably something I would not recommend to anybody. I grew up in Malta, which is a small island in the Mediterranean. It's between southern Italy, between Sicily and North Africa. And I grew up there, and it's a very small island, about 300,000 people. But when I was getting close to going to college, there was a fair bit of political turmoil in the island, and my family left. I was a teenager at the time, and we went to Canada. And as with many immigrant stories, two things. Number one is we went to Canada simply because we had an aunt there, and you go as an immigrant sort of where there is family connection. And secondly, it's because I wanted to make sure that I could get to university. And as a kid who was interested in health, broadly speaking, it was very clear to me that my path was I was going to become a doctor. There was no choice. I was going to become a doctor. So I went to Canada, went to college, and went to medical school. It was preordained, and no complaints. And I went to medical school, and I did residency in emergency medicine and primary care remote medicine. And then I practiced medicine in several remote parts of the world. I practiced in Papua New Guinea, in the Philippines, in northern Canada, and with Doctors Without Borders in Somalia. I was there a few years, this is in the late 90s, a few years after Black Hawk Down. So it was really very hands-on medicine. I was doing, I think, health in a real way. I was doing medicine in a real way. I was helping people with my own hands. And I became frustrated with the fact that everything I was doing felt transient. I felt like I was in Somalia for about a year, was my whole engagement. But I knew I was leaving, and I knew that when I left, nothing was going to change. And I started to say to myself, there must be a better way. There must be a way to change these things. And I really did not know anything about how to bring about change. I went to medical school at the University of Toronto, which is a great medical school. At the time, it was very conservative. I think it's changed quite a bit now. And really, I had no orientation into how one goes about creating health. And I decided I wanted to learn more about that. And I had heard a relatively distant colleague had done a master's of public health. And I thought, that sounds good. I like the sound of that. So let me get that. Now, there was no MPH in Canada at the time. So I came to the US, I came to Boston to do an MPH. And my intention was to somehow go back to medicine, but I fell in love with the idea of public health. I fell in love with the idea of being part of an enterprise that promotes health, not just cures illness. So I immigrated to this country, did a PhD, and now my career has been in academic public health ever since. So I think my journey has been one going from medicine, clinical medicine, care for sick patients, to thinking actively about how do we create health? How do we keep populations healthy? And that's been very practically my intellectual journey, and that mirrors actually my immigration journey.
Yeah, fascinating. Now, let's jump ahead to The Contagion next time. How did you come to write the book? And what was your main goal? Because you wrote this during the pandemic.
I did. The book just came out, which means I wrote it at the second half of 2020. And I didn't know when the pandemic was going to end. None of us did. None of us still know today, frankly. But I realized at the time that I thought, look, by the end of 2021, which is where we are now, we're going to see more books emerging about the pandemic. And that's a good thing, because there should be books that start to think about what is it that we've learned in the pandemic. And I thought we're going to be in the throes of books and ideas about how we can develop better vaccines and better therapeutics and better surveillance system and better stockpiling, all of which I think is necessary. But I wanted to write a book to inject in that conversation what I saw as the fundamental reason why COVID-19 was the tragedy it was in this country. And I don't think that reason was that we did not have a vaccine, that we did not have surveillance. I think at core, it was because we as a country were more vulnerable to the pandemic than we had to be. And we did not have the social and economic structures in place to protect us from a pandemic like this. And I wanted to get those ideas out on paper to be part of the conversation as we start collectively learning from COVID.
Mm. Well, in that context, I mentioned before that you chose a title that in one way sounds a little frightening, but in the other way, in reality, it's a really interesting literary nod to someone who also is a giant in racial justice. Can you talk about the title that you chose and how you came up with it?
Yeah. So the title, and I refer to this, I come to this in the conclusion of the book. The title is an homage to James Baldwin's The Fire Next Time, which is a book. It's actually a series of 2 long essays. It is, I think, one of the most sort of scathing indictments of racism and its effects in America. And I've always liked Baldwin's writing. I find it very difficult writing because it really makes you think. And I wanted to write a book about the forces that we take for granted. I think Baldwin meant it that way, that racism is just part of the American fabric and we need to change it, and that we need to change. And racism being one of them. This is not a book about racism. It's not a book only about racism, although racism is discussed. It is about the fact that we see health in a wrong way. We do not understand what generates health, and we need to change that to avoid the next pandemic. And I'm glad that you think the book is hopeful, because I meant it to be hopeful. And I made it to be hopeful because I have, perhaps coming back to the immigrant story, I have the immigrants' optimism in this country. I have the immigrants' belief that this country can do great things if it sets its mind to it. And I feel like we are misunderstanding health. And we've been misunderstanding it for a long time before the pandemic. The pandemic has just happened, but we have been misunderstanding health for decades. And once we understand health better, there is little that we cannot do.
Wow. It's interesting. I also am a student of public health. And so when I read your book, I thought, yeah, this totally makes sense. This is all about the social determinants of health. Thank you very much, Dr. Galea. And then I picked up some of the blurbs that others have written about the book. And I was startled to see that Publishers Weekly said that you are offering a revelatory new conception of public health and disease prevention. And you and I talked a little bit about this a couple days ago, and I thought, my goodness, two such different perceptions. You said that you're getting that a lot. Can you talk a little bit about that?
Yeah, I do get it a lot. And I think the two poles are as follows, is that I have people who, like yourself, Charlotte, you know health. You're sort of, you're thinking about it, you're writing about it, and people who are not. And for those who are swimming in the same pond as I am, I often get well, this is sort of obvious. We know this. For those who are not, I often get this is radical. Like, this is just a different way of thinking about it. Now, I don't think what I'm saying is either radical or obvious, to be honest. I think it's somewhere in the middle. I think I'm actually trying to bring what is now well understood in a small segment of the population, those of us who think about public health and the health of populations, and bring it to the general public for whom these may be new ideas, but I'm convinced that once they're understood, they will become commonplace. So my hope, I suppose, is to obviate the need for a book like this by making these ideas obvious indeed for everybody.
I see. Here in Philadelphia, the concepts that you're talking about have been so abundantly clear and have been for years. We live in a city where, depending on which zip code you're born in, you can expect 20 years more or less of life expectancy. And this has been known for years, but then when the pandemic hit, we immediately saw that the impact was so much more difficult and even deadly in our communities that were lower income, our communities of color. What have you been seeing in Boston? I know that you've been doing research through the pandemic. What sort of phenomena have you been seeing there?
I think Boston and Philadelphia are very similar in that way, that there are these more than 12-year differences in life expectancy, for example, between neighborhoods. And if I were to come to, you said these things have been evident in Philadelphia for a long time, and there's no doubt they've been evident in Philadelphia, evident in Boston, and they're evident nationally. But despite the fact that they're evident nationally, we have really made no moves to addressing them. I mean, one of the most remarkable things about this country is that we spend more on health, as you know, than any other country in the world, by quite a bit, by about 40% more than the next closest competitor. That means we're spending a lot of money. But our life expectancy, just for one measure, is worse than all other high-income countries. So we spend more and we get less. In fact, before the pandemic, in 2016, 2017, 2018, we had a downturn in life expectancy. Life expectancy was going backwards for the first time since the 1918 flu pandemic, ironically enough, that had happened for 3 years in a row. And at some level, one should ask, why is that not a headline every day? Country spends more on health than anybody else, has worse health than anybody else. By anybody else, I mean high-income countries. If you think about it, there is no other sector for which that's true. There's no other sector where we spend more and we get less. And if I were to say to anybody listening, if I were to tell you that your smartphone costs more than any other high-income country, but it holds less data, is slower, and the screen is less bright, you would say, well, something's wrong with our manufacturing. Like why are we accepting smartphones like that? But we accept this in health. So isn't that amazing? It really is incredible that we have accepted it. And that was, of course, before the pandemic. It had nothing to do with the pandemic. But that's the country the pandemic found. The pandemic hit us when the country was in that state. And the lesson for me is that while some of these ideas may be well settled in my mind, and frankly, they're well settled in the minds of my immediate colleagues, we do not as a country understand this well enough to actually act on it. And I'm hoping that the pandemic is the catalyst where we act on it.
One of the first things that one learns in public health school, speaking of investment, is that if you look at the scientific advances that have done the most to prolong life, they're not the exciting drugs and the amazing surgical procedures. It's things like clean water to deal with cholera. Vaccines are huge. But these are not very sexy things. Americans don't seem to be all that interested. Americans seem more interested in one test that's going to find cancer in the bloodstream or something like that. Why do you think that is?
I think these things are about what we talk about in the culture. In 1950, we might have been having this conversation where And we might be smoking a cigarette while we're talking, and we wouldn't even think twice about it because it's what everybody did. We all smoked. We've seen Mad Men. Everybody smokes all the time. And in fact, the prevalence of smoking among adults was up to almost 90%, right? It was ubiquitous. Everybody did it. Today, smoking is 10 to 15%. Now, how did that happen? Well, first of all, it took a long time. It took a long time for the change to happen. But it happened by the science. There was a showing that smoking is a carcinogen. There was a Surgeon General's report. People who were influential, people who were looked up to, celebrities, started coming out against smoking, and slowly over time, our attitude towards smoking changed. Similarly, I think our attitude towards these matters can also change. I think it can also change how we see health and what we accept as okay. To my mind, it's not okay that we live shorter and sicker lives than people in any other high-income country. It's not okay that we are not recognizing what we need to do, that we actually need to invest in housing, in the economy, in transportation, clean air, drinkable water to produce health. It's not okay that we don't recognize that the biggest triumph of the human species of the past 150 years is that we have doubled our life expectancy. Until about 1830, 1840, humans could expect to live till age 40. And that had been the case for thousands of years, for millennia. Starting 1830, 1840, our life expectancy shot up till now it's in the high 70s, almost doubled. Now, why did that happen? Well, it happened because of clean air and drinkable water, because of washing our hands, because of cleaning up our cities, because we developed better housing, because we developed parks and opportunity for exercise, we developed healthier foods. That's what happened. It had nothing to do, or very little to do with medicine. And that's a story that needs to be told. That's a story that needs to get out there. And there are good books that tell the story. And we simply need to make it a more commonly understood story so that we can recognize that that leads us to what we should be doing today.
Yes. At this point, I'd like to just take a short break and just tell the audience that even though I have about 9 million questions here and could probably talk to Dr. Galea for hours on end and drive you all crazy, I would really like to invite our audience to chime in with questions of your own so that we can make sure that your questions get answered too. So please don't hesitate to use that chat function. This obviously is a conference for writers about health stories. And one of the intriguing things I found in the Contagion Next Time was that you write about that sometimes the fact that the stories that we tell ourselves about health and wealth and who deserve health and wealth can perpetuate inequality. Can you elaborate on that? Can you talk about how writers can avoid telling the wrong stories?
Yes, I think we do that in two ways. I think one way in which we do that is by making the individualistic fallacy that says that health is all about you. It's about whether you choose to exercise, whether you choose to eat certain foods, whether you choose to smoke. Now, at some level, it's entirely true that there is a personal choice. But when we focus only on the personal choice, we forget that the personal choice is constrained by the context that makes the choice possible or not. I may choose to eat certain foods because those are the foods that are available to me. So I may choose within the foods that are available to me, but fundamentally, what's available to me constrains my choices. I may choose to exercise or not, but it depends whether or not I live in a neighborhood where I can step outside without fear of being shot. So our choices are constrained. So I think number one, we make that mistake by focusing only on individual choice without highlighting the broader context. And number two, I think we make that mistake by neglecting to note the element of luck that underlies everything about our health. A child born in Nigeria today can expect to live till age 50. A child born in Japan today can expect to live till age 80. A child born in a certain neighborhood in this country can expect to live till age 60. A child born in other neighborhoods can expect to live till age 75. That luck of birth determines our path, our trajectory of our life, and our trajectory of health. And I think we have a hard time describing and writing about us, our health, and extending it beyond me today to me throughout my life and me in my context. So to bring it back to core principles, it's that anything that happens to us as individuals is both has to be seen throughout a lifelong perspective and within our context.
Mm. Now, you mentioning luck reminds me of your previous book, Well, and you told me that the discussion of luck as it relates to health there really got some people kind of irritated. Can you talk a little bit more about that?
Yeah, we don't like to think that we're lucky. We really, it makes us uncomfortable. It makes us uncomfortable to say that I don't deserve to be able-bodied. I don't deserve to be sitting here breathing relatively safe air. I don't deserve to be sitting here in a neighborhood, because I think we have this notion, right? Well, I've worked hard for it. And working hard for something still doesn't mean that you have not been given enormous good fortune. Working hard for something, and let's take one concrete example. Let's just concretize in context of health. Let's take car accidents. So your chances of dying from a car accident today is about 200 times less than it was 100 years ago. That's an amazing, amazing improvement. Now, everybody listening will know why that improvement happened. It's because of seat belts and airbags and shatterproof glass and laws against driving under the influence of alcohol. Now, within that context, though, a safer driver is still less likely to get in a car accident than an unsafe driver, right? So we need to look at the driver, the individual, and the individual can be safe or unsafe. That matters. But is the individual driving in 2021, where our chance of dying from a car accident are very low, or is she driving in 1930, where one's chance of dying in a car accident were much higher? So there's the individual in the context, but then there's also the good fortune. The individual has the good fortune to be driving in 2021 or in 1930 or 1940. So we tend to ascribe it all to, well, if he doesn't get into a car accident, she doesn't get into a car accident, it's because they're a good driver. Well, that may be the case, but they also have the good fortune of being in a context that rewards that good driving versus being in a context that doesn't. And of course, if one were to get philosophical about it and go back to something like called Theory of Justice by John Rawls, which I write about in my previous book, well, we are born into our environment and we have no control over it. And that is determinative of so much else in our lives. And to my mind, that should give us pause before we lean on the much used word in the American lexicon, deserve, that we deserve X, to which I say, I never hear anybody say that, one doesn't deserve something. We all say we deserve this, we deserve it. Well, do we really? How much of what we have is really given to us thanks to no effort of our own, just thanks to our luck at our birth? And I just simply think that should inform how we see the world. And I think that should, if done right, result in humility and compassion that should inform how we talk about health.
The other thing I think that makes people uncomfortable is the notion that by talking about luck, you might be discounting the importance of personal autonomy and personal responsibility. But you also tell a really interesting story, I thought, in Well, about Blind Willie Johnson, that I think is a great way to illustrate some of the ways in which luck and also injustice and race play into health. Can you share that story with our audience? Because I think it's so important to hear this story.
Yeah, let me share a story, then I'll talk a little bit about personal autonomy. So Blind Willie Johnson was born in Texas at the turn of the 20th century, 1900 or so. And we remember him today because he recorded some blues songs that we still remember. He was born sighted, but the story is that he lost his vision at age 7 in a domestic violence incident. So he grew up poor, blind, black in Texas in the early 1900s. He got married and was living in a small house, but at one point the house burned down and him and his wife didn't have any money. Although they weren't hurt in the fire, when the fire died down, they went back and they were living essentially in the charred remains of the house. Wow. In the 1940s, so he was in his early 40s, he developed malaria. And this was Texas in the 1940s, where malaria was actually quite common. And his wife took him to hospital, and he was turned away from hospital. And it's not clear if he was turned away because he was poor, because he was black, or because he was blind. And then he died. Now, I tell that story to ask what killed Blind Willie Johnson. And the answer is malaria. Malaria killed him. Had he had treatment for malaria, he would have lived. But when you tell that story, I have yet to meet any human being who doesn't recognize right away that it wasn't just malaria. It was also racism. It was also access to care. It was also homelessness. It was domestic violence. It was poverty. All those forces conspired to contribute to his death of malaria today. And if not, it wasn't going to be malaria today. It was going to be pneumonia the next day. It was pneumonia the next day. It was going to be something else the next day. So we all understand that. That story, to my mind, illustrates, for example, that medicine matters, right? You need the medicine to treat malaria, but medicine itself is not enough. You need to deal with all these other forces that generate health. Now, similarly, let's come back to autonomy. You know, I consider myself in some respects a fairly classic liberal in my thinking. And by liberal, I mean liberal based on Enlightenment values. And Enlightenment era values, personal autonomy is core to Enlightenment era values, which means I actually want to make sure that I respect the autonomy of the individual and that individuals should have the space to choose. But I'm also acutely aware that our choices are always influenced by, shaped by, constrained by, or potentiated by the world around us. And I think in our health thinking, we have made the mistake for a very long time thinking that individual action is sufficient and a substitute for thinking about everything else. And it's simply wrong.
I see. You know, the other concept that you bring up in your writing that I think is probably one that a lot of people don't associate with medical doctors, no offense, but that is humility. And you have a whole chapter on humility. And I saw it and I sort of chuckled to myself. And then I thought, no, actually, this makes some sense. We have a lot of physicians. And as you just heard, we're about to get a lot of nurses who write for us at the Philadelphia Inquirer. And very often the best stories that people tell, that healthcare providers tell, involves a sort of a personal awakening that is very humbling to them. I've had doctors who think of themselves as real champions for low-income patients and patients of color. And then they realize that, you know, actually I have these biases that I wasn't even aware of. And these are very brave stories to tell. So can you talk a little bit about humility and how, sure, doctors, but really anybody can develop that sort of courage to really flex that muscle of humility, because it's not easy.
Yes, when you and I were talking about this earlier in the sort of prep green room, I made the comment that I think is true, that it's very awkward to talk about humility, because of course, if you think you're humble, it means you're not by definition, which is sort of paradoxical about how one wraps one's brain around it. But what I mean is, I do not think that one can genuinely be committed to promoting health in populations without recognizing the blessings of one's good fortune, without recognizing that there are many others who have been born in circumstances far more trying, born with genetic bad luck that is much more debilitating than ours, and in fact born at all, given the number of genetic mutations that result in us not being here. So that's one level of humility. The other level, I think, that humility matters is that it's a complex world out there, and it is difficult to wrap one's brain around what needs to be done to apply a prescription like the one I'm talking about. It's not so easy to think about how does one create a world that generates health. It's actually difficult to think that. And if there ever was a time for humility, it's a time now when we've been through this pandemic, where we've seen, or we're going through the pandemic, where we've seen time and again, how predictions about what the pandemic was going to do have turned out to be wrong. That where dispositive confidence, particularly dispositive confidence expressed in 120 characters or less, tends to be wrong. And I think a moment like this reminds us of the complexity of the human population and the complexity of the enterprise. One of the scholarship threads in my career has been thinking about complex systems. And complex systems approaches come typically from engineering, where engineers have really pioneered analytic methods to deal with systems that are very complex, that we need to do a lot of things in society. Well, human populations are also complex systems, and I've done some work with colleagues adapting that thinking to the health of human populations. And when you recognize that everything is complex, you recognize that we are well served by humility to recognize there's a lot we do not know.
But if there's anything this pandemic has shown us, it's that people do, in times of trouble, really cling to simplicity. I was struck that one of our nurses who spoke in the previous panel talked about how difficult it was to actually educate people and say, no, but science is like that. It changes. Just because you have one answer doesn't mean that it's going to stay that way forever and ever.
I suppose I want to have confidence, and I think people can handle complex truths. You know, it reminds one of the classic Jack Nicholson speech in Few Good Men. You can't handle the truth, and I think there's arrogance to that. There's arrogance to you can't handle the truth. The implicitly is I can handle the truth. You can't handle the truth, and I just don't think that's correct. I think we, the people, can handle the truth if it's conveyed with appropriate humility and with appropriate recognition of uncertainty. In fact, there are experiments in psychology that show that when people are told complex truths with uncertainties, told here's what we think, but here's what we don't know, people do not undervalue the person telling them that. So if you have two people, one says the answer is X and that's what it is, or somebody says, well, I think the answer is X, but here are my caveats as to behind that. People are able to look at those two and give them similar weighting. And in a time when answers are changing so rapidly, we would be so much better served by being honest, by actually assuming that people can handle the truth. And of course, we did not do that during COVID. I mean, we were Colonel Jessup in A Few Good Men saying, you can't handle the truth. Let's give you a few simplifications. And then we kept changing our minds about that because, of course, we did not know what the truth was to begin with. So I think we suffered from an abundance of arrogance and a shortage of humility during COVID-19. And I suppose I'm trying to draw attention to that while recognizing the irony about the arrogance of even pointing out a surfeit of humility.
Yeah. Well, and it was so interesting because we saw it coming from, it wasn't all coming from one side. I mean, we saw some of it in the Trump administration, but we also saw it in some of the public health establishments.
Yeah, you know, I think we've had the bipartisan arrogance. Actually, it's been helpful that way to see the world for what it is.
So the other thing that the pandemic revealed so much, but one of the things it revealed was how severely underfunded and understaffed the public health infrastructure in this country has been. Do you see any reason to think that we've learned our lesson? Or when we talk about the contagion next time, is there reason to think that we will have a more robust public health infrastructure to handle it?
I suppose my answer to that is, if not now, when? If we do not learn our lesson about needing to invest in public health infrastructure when we're moving through a pandemic that has killed 700,000 Americans, that became in 2020 the third leading cause of death for a disease we had never heard of before, came out of nowhere, became the third leading cause of death after heart disease and cancer. I don't know when we'd invest in public health. And we have underinvested. Today, we have fewer people working in public health at the municipal, state, and federal level than we did 10 years ago, because the number of people working in these agencies has been going down because we've been underfunding it. Although there have been federal laws like the Federal Prevention Fund, typically what has happened is those monies are not spent. They're reappropriated for something else. And typically what happens after there is a public health scare is we do a bolus of money. We inject a bolus of money into the public health system, and then we take it away. And surely we all recognize now that that's a mistake, that we should not do that. And it's time to build up a world-class public health infrastructure, which we can do. We know how to do. We have excellent people in public health practice in this country, and we should let them lead us towards building a first-rate public health system so that the next pandemic hits, we can do testing in time, we can do screening and contact tracing in time, and contain it, among other things, before it becomes a pandemic.
Absolutely. Well, tell me something about the pipeline. You are producing the public health leaders of the future. What are things like at your level?
The pipeline fills me with joy and enthusiasm because we have outstanding young professionals who are interested in making public health their life's work. We've had an increase, about 20-30% increase in interest in our programs, as have other schools and programs of public health across the country. And when I talk to our students, when I see our students, I think they're extraordinary. They are better, smarter, more dedicated than I was and my generation was at their time, and it fills me with hope that they are going to do the right thing today. In fact, I actually had the privilege of speaking at a high school about public health, and wow, these high school students are extraordinary. They are great. So when I look at the future, I think the future is bright. We in this current generation that is currently in charge, need to do what we can and not mess things up so that they can take over, and they're going to do better than we did.
Are you doing more work now in colleges of public health to emphasize the storytelling part, the communications aspect? Because that's definitely something that we really fell down on in this pandemic.
We did,
communication.
Yeah, we are. So we have in our program, for example, our program is designed that students can choose certificates that they can take, and one of them actually is on public health communication. And other schools have similar ideas. But they're relatively new. These ideas, they're relatively new. Public health communication has been, I think, under thought through, and you're completely correct, Charlotte, that I think we saw this and we paid the price for that in this pandemic. In fact, if there's anything that this pandemic taught us, is that the things we invested in, we did well. The things we did not invest in, we did poorly. I mean, we have spent decades investing in the technology for the mRNA platforms that became these amazing, safe, efficacious vaccines. And we did very well. We've spent decades investing in health care, clinical care, and our hospitals did a very good job of caring for very sick people from an unusual disease. We have spent decades underinvesting in creating a healthy population. And as a result, we had a sick population that was hit very hard by the virus. We have spent decades underinvesting in public health. As a result, we had a public health infrastructure that was ill-prepared for this virus. So to my mind, I take a step back and I say, that shows me that actually this country can do things right once it sets its mind to it. And I suppose my job, and the reason we're having this conversation, the reason I wrote this book, is to try to make sure that we invest in the fundamentals that can generate health and in a public health infrastructure to make sure that we can stay healthy.
Yeah. It's so amazing. I saw a study the other day indicating that in Great Britain, rates of cervical cancer, the cervical cancer is virtually disappearing because the HPV vaccine has been so popular. And apparently it was communicated there as an anti-cancer vaccine. And in this country, everybody got all worked up over it having something to do with sex. And as a result, we are continuing to see very, very high rates of HPV-related cancers. And I thought, boy, if that isn't the best example of the need for better health communication, I just don't know what is.
That's a terrific example. We have huge sectors of the private sector where we have people who are terrific at communicating messages that lead to product purchase, to the best way to communicate the kind of food that you may want to eat. And we are so good at that. And we have yet to break through and apply those lessons to the need for health communication. We'll get there, but I think we need to get there sooner rather than later.
Yeah, that's the truth. So keeping with storytelling, I was struck in reading your book. You tell an amazing range of stories to support the points you're making. I am very certain, as I told you the other day, that I have never read a public health book that cites Richard III. Can you, are you that well read, or how do you find all these stories?
Well, we're a very collaborative group here in the Dean's Office of the School of Public Health. And we have a small group of 3 of us, and we brainstorm a lot of these things. And, different ones of us have ideas, and we're like, oh yeah, I had read that. Oh, I had come across that. And they all eventually make their way, and then they go into the writing and they become written examples. In my previous book, I was, somebody had pointed out that The Devil Wears Prada made its way into that book. And these are things that sort of come to me. And I'm like, we can use them to illustrate the broader point. And it's sort of fun. Mm-hmm. It's fun to do that, to illustrate the broader point. And you're right, public health has not done that, which just goes to show how public health has not been good at telling its stories. Medicine has been. Medicine has done a very nice job of telling the doctor story in many ways, with the doctor novelists and with writers who write about medicine and the sort of both the soul of medicine and the practice of medicine. But we have not had the same effort in public health, and I would argue that it's even more important. I'm trying to make my very small piece of that effort come to life to encourage others who I'm sure can do this even better than I can.
Well, I really commend you, because there are so many places in the book where I thought, even somebody who is not a total public health geek like I am would really enjoy this, this historic reference, or, wonderful artistic reference. There's a painting in there. It's a shipwreck.
Yes, yes.
I thought, well, that's really clever. Can you talk a little bit about how that happened?
Yes, it's Jericho's painting. It's which is, it is a story, a sort of prototypical story that it's a painting which I've seen and liked, and it emerged that it sort of fit into that part of the story. And actually, there was a book about that very painting which I hadn't fully read, but I had browsed at some point in time. It had appeared in Julian Barnes' book. What was it called? The Story of the World in 8.5 Days, or something like that, which actually the painting features in as well. So it had been rattling around in my brain, and then it fit into the point I was trying to make there, and there it was. And one of the beauties of actually writing a book like this is that one has the license to use examples to illuminate points, and the publisher generously allows me to do that, which I'm grateful for.
So, you've written how many books now?
Well, this is my second book intended for a broad audience. It is sort of my 18th or 19th book overall, but most of my books have been intended for a scientific audience, for an audience of peers, more than that. But this is my second book intended for any reader. Okay,
so it sounds like you just crank out books like some people make breakfast. Just kidding. But seriously, what kind of advice would you have for healthcare practitioners or advocates, or really anyone who has a lot of great ideas and they just don't know how to get started? How do you get started on writing a book?
Well, I suppose what I do is I write standalone shorter pieces, because I don't have time, and I'm intimidated by the idea of writing a book, so many pages. So all the books I've written, both this book and the last book, for general audience, but also my books meant for a more technical audience of colleagues, they're not written as much as books as one continuum. They're written as they're outlined, and then within the outline, I'm writing pieces, and often not in sequence, not in the actual sequence in which they appear in the book. But I write sort of I can do 1,000 words like fairly cohesively in a relatively short time, and then those 1,000 words string together and they become a book. So I suppose my advice would be, don't see it as a big daunting project. See it as a series of much more digestible, smaller projects.
That's really very good advice for all sorts of endeavors, like getting your health in gear, or all kinds of things.
No, it probably doesn't apply if you're writing a novel, where which I've never written. I don't think I have a talent for, where you have to go from beginning to end. But I think for this kind of book, I think you can write it in pieces that can string together and rearranged.
Wonderful. So what's your next project?
Well, what I'm working on now is I've been doing this series of blogs, which go under the broad name, The Healthiest Goldfish, which I've been doing on Substack for the past year.
Which is a wonderful blog. Can you talk about that a little bit? Goldfish. It's really fun.
It comes out it's free. It comes out every Saturday morning. And I've been writing these essays, again, these 1,000-word pieces, roughly 1,000 words, about my thoughts on things about public health in the moment of the pandemic that are perhaps a little bit off what people are writing about. I'm not writing about my predictions for what's happening with the virus. I'm not writing about mask wearing. I'm writing about, for example, what's coming this tomorrow is about populism in public health and the role that populism may play in public health. And my next project will be to go back to these pieces and now build those up into a book that the current working title is Within Reason, to talk about what I'm hoping will be an agenda for public health, a liberal public health agenda, an agenda for public health that recognizes the role of individual autonomy within the role of data, informing reason, the role of public health, listening to a plurality of voices. And really a bit of it is in reaction to what I think have been the missteps of public health in a time of a pandemic. But I suppose it fits in with the previous question you asked me about how I've done my writing. So It's been written over the course of this year, bit by bit. And then at the end of this year, I will go back and then rewrite and remold and reshape and build these pieces together into a book.
Great. Now, when we talked a few days ago, I asked you what the very most important point was that you wanted to make sure that our audience heard. And you made it earlier in our interview, but I'd like to go over that again, your point about the lessons we absolutely must learn from this pandemic.
The lesson at the heart of this book is that unless we tend to the structures that shape our world, the economic structures that, for example, push some people to have to work in real time, even if they're at risk of getting the virus, the structures that predispose particular groups, particularly people of color, particularly Black Americans, to be at greater risk of underlying hypertension, diabetes, respiratory disease, and then to be at greater risk of severity from the virus. Unless we tend to those structures, and those structures range from housing to transportation to economic development to gender equity to livable wages, it doesn't matter what else we do about pandemics. It doesn't matter how much we invest in vaccines, in surveillance systems, in stockpiling. The next pandemic will hit, and we will still do poorly as a country. So the fundamental message is we need to focus on the medicines, yes, but that's only a part of it, that everything else in our society is equally as and probably more important to how we do in the time of pandemic than are the more obvious medical approaches like vaccines.
Wonderful. Well, what a important and inspiring way to conclude our interview. I thank you so much for your time, Dr. Galea. You have set us up for the perfect, actually, introduction for our next program, which will start at 4 o'clock. And that is Dr. Ayla Stanford, who is just an icon in health now in Philadelphia and well beyond. And so she'll be coming to us to talk more about these sorts of issues of health equity that Dr. Galea has been exploring so eloquently here and also in his book, The Contagion Next Time. I highly recommend it if you haven't already read it. It's a very important book. So everyone can take a little break now, and we will be back at 4 o'clock, and we'll see you then. Thank you.
You have the power to stop this virus.
By being fully vaccinated, you are not only protecting yourself, but also those who are unable to get the vaccine,
such as children under the age of 12.
Our greatest tool to beat COVID-19 and its variants is in your hands, Philadelphia.
And we're counting on you to use it.
Juntos hay que proteger nuestra comunidad y vacunarnos hoy.
Together we will beat COVID-19.
Thank you for your patience. I am so pleased for our final segment to welcome back to the Inquirer stage Dr. Ayla Stanford. Dr. Stanford is a pediatric surgeon and Philadelphia native who saw before almost anyone else what COVID-19 was doing to the community that she loves. And what's more, she immediately swung into action to help out the community. Today, she is a nationally applauded authority on the pandemic and the broader issues of health equity that it helped illuminate. And she just opened the Dr. Ayla Stanford Center for Health Equity in North Philly, where I believe she has been seeing patients all day long. And that's why we're getting a little bit of a late start, because you know how doctors' offices run. It's so fitting today that she is with us in for this final segment, because all the way back in March, Dr. Stanford was my first guest for our year-long Inquirer Live Health Report series. And she took us behind the scenes then at one of her famous community vaccination clinics. Today, she is joining my Inquirer colleague, Janice Armstrong, in conversation. And this is also fitting because Janice first wrote about Dr. Stanford over a decade ago, when she performed a series of operations on a little girl from Haiti who otherwise faced certain death. Since then, Janice has spoken with Dr. Stanford many times, and I'm so grateful that they're sharing their next discussion with all of us. So welcome to Janice Armstrong and Dr. Ayla Stanford.
For that introduction. Hey, Dr. Stanford.
Well, hello, Janice. How are you?
I'm fine, thank you.
Good.
So,
good.
Thanks for joining us.
Of course.
Busy day, huh?
Little bit. I mean, you know, it's funny because part of me was like, it's raining. Maybe we won't be busy today. But that was not true. People were here in the rain. Then the sun came out and everybody came. We've been open for 9 days and we are seeing a flow of somewhere between 75 to 100 people a day. It's a lot.
It's a lot. Is that about what you planned on, or is it a whole lot more?
I wasn't sure what to expect. You know, immunizations, vaccines are one thing, but coming as your primary care provider, I was not sure. Then there are some people who just come and say, I wanted to see about switching my care, and they're just kind of curious. And then there's some people who come and get their shot and then say, well, are you accepting new patients? And so it's been, I mean, still a lot of folks getting boosters, a lot of kids coming now with their parents, but other people establishing their care here with us. And I mean, everyone from I have no insurance and I have no teeth to I have platinum, IBC, personal choice. And so people who speak English as a second language, young folks, old folks, everybody in between, church folks, neighborhood folks, high schoolers, someone recently released from prison that we had to report to their PO. It's everybody.
Well, you built up so much trust. I know so many people who, when the vaccine first came out, said, I'm not going to get vaccinated unless Dr. Stanford or one of her doctors does it. Oh. So many people said that to me. So anyway, we're going to, let's just jump right into it because we don't have a whole lot of time. This is, oh my God, this crazy desk. Just a second, sorry about that. This is the conference that's all about telling your health story. So for those of you who might not be as familiar with your story as I am, can you just start at the beginning and tell us what influenced your decision to become a physician in the first place?
Oh my goodness.
Yeah, every story starts at the beginning, right?
So I loved science. It challenged me. It intrigued me. I had to study to get it right. I always wanted to learn more. So that was the one part. The other part was I was tired of being poor. And we used to go to Health Center number 5 in Germantown. And there was a doctor there who looked like me. And she seemed to be happy. Her clothes were nice. You know, and I was thinking, well, what does this person do? You know, she's a doctor. And I thought maybe I wouldn't have to work as hard as my parents seemed to work and never have enough money. So for me, it was a win-win that maybe I could have everything I needed and most of the things I wanted by making enough as a doctor. And also intellectually, it challenged me. So that's why medicine.
So you were right on one hand. And how about the other part about working? You didn't want to work as hard as your parents.
Oh, right.
How did that work out for you?
It has not worked out at all.
That's okay. Well, let's jump ahead to like midway through the book. It's 2019, April. You know, those are really scary times. That was a really scary time. You know, you think back. People were waiting in lines to get long lines to get vaccinated. People were quarantining at home. You were too. Tell me what went through your mind and how it galvanized you to jump in that white van and start going out and vaccinating people.
I mean, just seeing the faces of, you know, CNN started doing this, people we've lost to COVID in the beginning. And they would put pictures up of crossing guards and police officers and EMTs and doctors and nurses. And it wasn't lost on me that there were a lot of Black and brown faces. I mean, that's what there were. And, you know, now that we're back into our sort of new normal, people forget there were so many bodies that the graves were unmarked and people were being buried on top of each other in New York. Like, people forget that. So for me, as I was watching it and knowing that there was no cure, all you could do is, if you knew you were positive, hydrate, know as fast as you could so you weren't sitting around getting worse. And if you did, that you could seek care and then not spread it to others, which meant you needed a test and you needed some sort of contact tracing. And as a surgeon, I thought, surely I can provide that. Surely I can provide that. I had personal protective equipment, mask, gown, gloves, shields, all of that for being in the OR and doing procedures in my office. And I needed testing kits, which all the primary care offices that closed because of the pandemic, they were the ones that had the kits in their offices, but they weren't using them. So I drove to my other doctors and grabbed these testing kits and I took them. Then I needed transportation and I needed to know where people were. So I put something out on my private practice website and basically said, if you need a COVID test, send me an email. That was it. And that's how. And why? Because I couldn't, it seemed like this is the problem. Here's an intermediate solution. These people are dying disproportionately because they don't have access to this solution. So I'm going to provide it. And that's the rest is history, I guess.
It really was. And one key decision you made, I think, really helped play into your success in terms of getting people to come out. And that was by setting up in church parking lots. Can you talk a little bit about why you decided to go that route?
Absolutely. So the church, particularly the Black church, is a place of trust. It's a pinnacle. It's even if you don't go to church and you don't believe in God, it's a place of refuge. It's a place of peace. It's where you can get clothes, you can get food, you can have shelter, and you can find some sense of understanding, and everyone knows it in the community. So to put things at that location, people were able to come. And we didn't just go to churches, we went to masjids as well. You know, sometimes we were on street corners, but the church was also, and it is, one of the few things that African Americans own in the United States. So I didn't have to get permission from the city or the state or federal government to be on their property. I just had to call the pastors. And fortunately, through my pastor at Salem Baptist Church and his relationships with other pastors, was able to pick up the phone and say, this doc is trying to save lives. Can we use the electricity in your building and stay outside in your parking lot? To everyone said, absolutely, yes, you may.
Skipping ahead again, once we had the vaccine, you were one of the first in the area to be publicly vaccinated. Can you talk a little bit about what went into that decision? Because it was a little early for you to get vaccinated too, wasn't it?
It was early, December 16th. It was a Wednesday. It was the snowstorm, actually. And, my large part of getting vaccinated was because so many people were looking at me. I'd had COVID in August of 2020. I knew I had some level of protection from going to my doctor and him drawing my labs and seeing that I had antibodies that were protective, not as protective as the vaccine, but that I did have antibodies. And so I was willing to wait until we learned more about things. But people kept saying, Doc, when you tell me it's okay, I'll get it. If you get it, I will.
I was one of them.
Yes, I'll do it. And so, and I can tell you the night that I made that decision, I cried. I was like, oh my God, is this the right thing to do? And, God, this isn't for me. This is for other people. And, how far are you willing to go to sacrifice, for others? And I prayed about it. I cried on it. And the next morning I said, okay, I'm going to take the vaccine as soon as it's available. My husband was like, you are? I thought we were waiting. What happened? And so, I did, but it was important for me to do that publicly. And there was just this, and a lot of people will tell you this, especially back then. I don't know as much now, but there was this sense of relief, like maybe things will get better now. It was tears for all the people you knew who had gotten very sick and who weren't the same, and all the people who had gotten sick and died. You felt that, and it was just a huge release that we were embracing each other and crying and just optimistic for brighter days. And so the publicly was because I wanted people to see that, and I wanted to talk about how I felt after receiving it. That I would be the first, so I could tell you what to expect. So maybe you wouldn't have as much trepidation as I did, perhaps.
Well, thank you for that, because you really reassured me once you stepped forward like that. Let's talk about vaccine hesitancy. Is it really as big a problem in the Black community as we keep hearing about?
So, no. And evidence to that was the fact that we did our first vaccination on January 16th, Martin Luther King weekend. We found out the Wednesday prior, January 13th, that we would have access. And on January 11th, we put out a link and said, we might be getting vaccine. Please let us know if you're interested. Within 48 hours, we had thousands of people, primarily people of color, who had signed up. And I remember initially the city saying, people, we can't, because you didn't have a lot of vaccine then, and they weren't going to give it to me because the idea that there was hesitancy and people weren't going to come, they didn't want to allocate it to me to be open and for no one to show up. Right. And I anticipated that, which is why I put the link out first. And I could say, oh no, I already have over 1,000 people signed up for the vaccine. So if it's only 1,001, they're ready this weekend. And after some back and forth with the Department of Health, we were able to receive the vaccine.
Mm-hmm. And I think how about vaccine hesitancy now, almost a year later? I mean, we're getting better about it, or?
It's better. As much as people hate it, the mandates are helping. Mm-hmm. A lot. The mandates are helping because, it's forcing people to say, am I really against the vaccine? Like, what's my reason for not wanting it? And when they look at that versus their ability to support their family, their livelihood, how are you going to pay your rent, feed yourself, then they have to make a choice. And they're saying, I'm mad. And I mean, I out here. Oh, I'm glad with the school district. I'm here to answer your questions. You know, what do you need? You know, blah, blah, blah. I don't need any questions, answers. Where's the shot? Look, where's the damn shot? You know, and they were pissed, but they recognized the urgency of you're not going to get paid unless you are vaccinated. And whatever the reason it was, it wasn't so serious that they did not get vaccinated. The other folks that are coming in now are people who are starting to be touched personally. So a family member has it. You know, they saw someone closer to them get sick. And then the kids. I just had a child in here today, teenager, who was not able to participate in certain things, wasn't able to go to an event, go to a dance, you know, go to a concert or whichever, because many are saying, I don't want a 72-hour, you know, PCR. I want fully vaccinated for you to gain entry. And for the teenagers, they're like, well, I want to be able to be where my friends are. So for them, that's motivation to also get vaccinated.
Yes. So I apologize for jumping ahead so much. You got so many great layers to your story, but I want to talk a little bit about your latest accomplishment, the Dr. Ayla Stanford Center for Health Equity. What made you decide to call it that?
Ooh, boy, Janice, these questions are good. You know, it's interesting. So first I thought about, you know, Sojourner Truth. You know, Jocelyn Elders, people like that. And then I thought, you know, Kimmel, and I have friends who are Kimmel, so this is no shade to them. Their names are all over the buildings in Philadelphia, all over, because they are philanthropists, because they give for whatever reason, because they bought a wing or whatever. And I said to myself, why do I either have to wait to be dead for someone to name it after me, or, you know, wait for someone to bestow it? I am very proud of what I've built with my colleagues, that it was my vision that became a shared vision for all of us, and for it to be recognizable to the children, and for that matter, the adults in this community of where they're going. And some people say, call it Stanford Center. I said, no, I want you to know the full name of who. Yeah. There's other Stanfords out there. I want this to be clear who and what it was. And that is a sense of pride that I hear from people as they're here waiting sometimes, because we have walk-ins and we have appointments, waiting for 2 hours. Oh no, we'll wait. You know, sorry for the wait. There's so many people. That's okay. And they enjoy sitting in our welcome center and talking to folks. I like to call it fellowship, because they're catching up on this and catching up on that in the space. The kids are drawing pictures and looking at the fish in the fish tank here and so forth. And so that's why I called it, you know, the name. And people are, so we are still the Black Doctors Consortium. We were COVID-19 Consortium, of which we took the COVID-19 out, because by this time I really thought we were going to be beyond it, but planned for it. So Black Doctors Consortium in the Dr. Ayla Stanford Center for Health Equity. And I want this to outlive me, right? Just like Health Center number 5 is still over there, that this should still be here, you know, when my kids are grandparents.
Let's see, I've got a question from the audience. Here it is. Have you had time to process the past 2 years, and has storytelling, writing, or speaking helped you work through it? You're a really good writer, you know? I always marvel when you whip out these op-eds. When you, number one, when you have the time to write it, and number two, dang, she can write too.
I am very much a journal person. I've always been, I've got journals from high school where it was really cathartic for me to write about my feelings. If I didn't have someone I could trust, I felt like I was talking to myself, I was talking to God, and that's how I was able to process. No, I haven't. You know, every once in a while, you know, when you come up to something that has your name on it in the morning, it's it's a bit much. And you think about that. It's just been a journey. And no, I'm looking forward to Thanksgiving and having some days off with my family to just reflect a little bit. Really looking forward to that, because it's been a whirlwind. Every time you think things are going to slow down a little bit, something else happens, So I'm looking forward to everything being closed and turning off my phone.
For one day. Yeah, for one day.
And just, maybe reflect. But yes, writing helps me. Writing helps a lot.
Mm-hmm. Here's another question from the audience, and it is, how did technology hinder the vaccination process for Black and Brown communities?
So yes. So first, I'm going to talk about testing. In the beginning, we used forms. We had clipboards that we wiped down with a piece of paper that people could sign up. And so there was no, you have to fill out this link or, download this app to register for a test. All you had to do was show up. We didn't ask for an ID. I mean, it helped. All I needed was your name and a way to contact you with your test results. And so we got rid of all that stuff, right? I remember, and literally at Bloomingdale's one day, and it was a older white woman, and she said to me, I was trying to get on one of these lists and it used all my data to try to register to get a COVID vaccine. Oh my God, So that's one example. The other thing was we were doing paper. And because we were doing 400 a day, 500 a day, eventually LabCorp said, we can't process these. If you don't start to do it electronically, we can no longer process your tests. And so in 48 hours, we had to convert from paper to digital, which was very challenging for us to do, for everybody to get up to speed. We were outside in the summer, so it wasn't uncommon for our computers and our printers to just shut down because, your iPhone thing would say it's too hot, go cool down your device. So that slowed us down because we were outside in all temperatures. And then ultimately that link I talked about, January 11th, in the beginning, because I could look at our demographics and analytics, 96% of people were African-American. By a week later, it had decreased to 50% African-American. And that was twofold. One was because of the digital divide, and all the people who had computers and had phones, they had completed it. The other was because Philly Fighting COVID went debunked, and everybody who was going to them was now coming to us. Mm-hmm. And so that's where we saw that was really an issue, because people didn't know how to register. They didn't have data, but they knew how to show up. And unfortunately, or fortunately for African Americans, are used to waiting in line to vote, for backpacks, for food, pick a something. So we would come in the morning and folks would be outside 5 o'clock, 6 o'clock in the morning with blankets and chairs and thermos, dressed and prepared to wait. Yes. Had no problem waiting as long as they came for what they were waiting for. And that people got. The digital thing, they didn't get so much. But if they got word of mouth, they heard it in church, they heard it on the street, heard it in the barbershop, that we were here, they showed up.
And it was cold and they were showing up. I remember the 24-hour clinics and one of my friends going around getting all the old people on her block and bringing them. At 3 o'clock in the morning,
yes,
she went and got them.
Oh, that was you. That was them that dropped that van off.
Yeah, that was one of my friends.
It had finally slowed down. It was like 3:30, 4 o'clock. I was like, oh my gosh, can I just put my head on the desk for a minute? And someone dropped off 2 van full senior citizen. I was like, what is happening?
I think that was my girl.
Yeah. Oh, we remember.
Yes. Well, she thought it out. She says, when's the best time to come?
Yeah.
3 o'clock in the morning.
Yeah.
And they were also excited, she said, and happy to be there, not complaining about getting up early. They were happy.
No, they weren't. The seniors never, it was never the seniors who complained. It was unfortunately the us group in between a little bit. But I mean, you would walk the line and there's like 74-year-old grandma. You're like, why didn't you say something? Look, it's all right, baby. I'll wait. No, you're going to come with me. And, so we started bringing folks in who were in wheelchairs or disabled or were hypoglycemic because they were diabetic and they couldn't eat because they were in line for so long. So we started, bringing folks in. And once we were able to really utilize Leah Chorus, which was really a godsend. So let me just put a shout out to Leah Chorus and Temple for letting us use that space. Because it was so vast, we were able to spread people out and then start to bring more people inside, especially in the cold winter days.
Years from now, when we tell these stories, people aren't going to believe us, are they? What we went through, what we endured.
No, not at all.
Now, here's another one of my questions I have. How do we make our healthcare system more equitable so more people can access it and get their basic needs met? How do we help prepare ourselves for the next time something like this?
Right.
God forbid.
So certainly having a relationship with a doctor would help. The reason why we were so busy is because the healthcare system has been largely untrustworthy to African Americans. And I'm not even going to say people of color. I'm going to say African Americans, because that is the history, unfortunately, in this country, where surgical procedures were performed on slave women without their consent, without anesthesia, so the procedure could be perfected in Black women before it was used on white women. Okay, like that happened right here in the United States. Okay, and then everyone talks about Tuskegee, but there were other things, at some of our hospitals right here where prisoners were used without their consent to conduct experiments. And then you look at coronavirus, and it's like all the testing were in affluent white neighborhoods, but the communities that needed it the most, that were most impacted, you couldn't find a testing location in these communities, right? So how you make it different now during this sort of post-COVID, even though we're still in the midst period, is that people have established relationships. So you're getting preventative care to treat your hypertension, to be screened for types of cancer, to deal with mental health and emotional health issues. So you have a place to call to say, hey, Dr. Stanford, I heard I needed to get a booster. I heard I needed to get a vaccine. When can I come? And they're not, one, sick, and then searching for a provider at the same time. In the midst of a crisis, certain people just will not make it if they've got to do both while they're sick. And so the Center for Health Equity is one of the ways that we get to that. God forbid we're ever in this situation again or something similar to it.
Mm-hmm. One possible chapter in your story, you sort of skipped over, or you said, no, not now, maybe never. And that's when you took your name out of the running to be the next public health commissioner in Philadelphia. Can you talk a little bit about that decision?
Yeah, I mean, that was hard because personally, that would have been a professional challenge for me, right? Like I wanted to deal with air pollution and rodents and the things in our restaurants, and asthma and cancer and cardiac disease and maternal and infant mortality and the medical examiner's office and all these things that are an issue in our city health department. Like I wanted that challenge to be able to advocate for the voiceless and push professionally. I wanted to do that. I realized, however, that in doing that, it potentially blocked sources of funding from the city for this Center for Health Equity, right? To be able to get funds from the state or from the federal government, because there's a conflict of interest, because so much of that has to be signed off or green lighted by the health commissioner.
Yeah.
And I learned that during my interview process. And so it's interesting, and I could talk about Will here for a minute, but he has his book out. And one of the things he talked about that resonated with me was desire versus purpose. And desire is something you want for yourself. Like I wanted that position for myself. But purpose is when what you do impacts others. And it's less about you and it's more about your impact on their lives, right? And in that moment, I realized it wasn't about my desire or my professional aspirations. It was about the hundreds of thousands of people that we are impacting here. And by potentially taking that job, not potentially, because it was a clear conflict, I would be blocking what's happening right now and the ability for it to be sustainable. And as I said, outlive me.
Mm-hmm.
So.
And the Will she's talking about, folks, is Will Smith. She's not a name dropper, but I am.
No, I mean, he said that and it just really stuck with me. Because I just had that decision in the last month. And it was a personal, desire for myself versus a purpose-driven, vision and mission for the underserved in the city.
This whole conference is about writing. And this is something I've wondered about you a couple of times, well, maybe more than a couple. When are you going to sit down and write out your own story? I mean, it's a heck of a story.
Well, I mean, it is coming out this month. That I do have a book deal, and I didn't.
What? Tell. We're breaking news here, folks. Tell us about it.
So I'm not going to say the publishing company and all that, but I will say it's a pretty good one with lots of New York Times bestsellers. Yes. And I submitted a proposal. My literary agent, sent it out to different publishing companies. And literally within a week, I had interviews to meet with the different editors to talk about who the audience was. What story am I wanting to tell? What do I want people to get from it? And after doing that, an offer was made. And I was, wow, this is great. So
congratulations. That's excellent.
But
when is it due?
So it's supposed to be due before all the editing, September 2022. And then it goes through the whole editing process and whatnot before it goes on the shelves and sold to bookstores and all this kind of stuff. It's very complex procedure, but I was excited with this company. They seem to be very excited about me. It's a whole love fest going on here. So
They're very smart. They're very smart. How are you going to find time in your day to write? How are you going to do it?
So as I was doing just for the proposal, for me, like what we're doing right now, the interview and it being recording. So you asking me questions or, the writer with me that I'm writing with, asking questions and us going through an outline about the story and so much of it being recorded. So it's my voice, right? And then putting that on paper and then supplementing that story with, the factual components of it and the historical information to, support and things. So that I think is a big, big part of it. And then I'm always, I've got my, my journal right here. And I'm always, when I think of something or something moves me, I write it. Or like I said, I'm reading Will's book. I took the cover off because I like to keep my jackets clean. And I write notes. Like when he says something, that's whichever, then I write my little notes in the back. And that's how, and I've always been that way. I've been that way since I was a kid, like highlighting and underlining in books and journaling. So that's how it'll get done, I believe.
Yes. Are you going to meet like on a daily basis, a weekly basis? How are you going to do it?
Some of that he left up to me. I think it's going to be more, like crunch time. Like we might go hard for 2 weeks and then all that information gets transcribed and put in, a narrative sort of manuscript form on paper. Then the next 2 weeks is me going through it and putting my scribbling and notes and things like that, and then going on to the next. So, yeah.
Well, this is going to be a process. Have you got a working title in mind?
Oh, I'm not going to say, but I do. I'm not going to say because
the Dr. Ayla Stanford story or something like that, and then like something underneath it. No, it's got to be something bold, and then something like the Dr. Ayla Stanford story. Yeah.
The subtitle, it is.
The subtitle is that. We could tell you whether we think it's good or not. We could be your core group.
Look, my literary agent's already going to be mad at me for running my mouth.
Well, I won't write about it. How about that?
No.
We'll just let it.
No, but I do think this month, because it's been since September, so I do think November is when we sort of make the announcements. I feel okay talking about it. I've signed it. They've signed it, so I feel okay. Yeah.
And you know what? I hate to project. I'm already seeing it. I'm seeing it on the big screen. Sorry.
Oh, well, so and I'm just a friend of mine, I won't say who, started calling me NWP. I was like, what is NWP? Nobel Prize winner. MPW. He walks around, all right, MPW, how you doing? I'm like, what?
Wow. I mean, I think I heard you someplace talking about where we are in Philadelphia in terms of the vaccination rate. We're a lot ahead of a lot of other major cities.
That is correct.
That's because of what? And what is that? Why is that?
That's our work. That is, and I will take full credit for that. Full credit, not me just personally, but the Black Doctors COVID-19 Consortium. When that came out in Bloomberg News, I was floored, that the rate, but not surprising. I mean, we've been at this every single day for like going on 19 months, and not because it was our job or because someone asked us to do it, but because we saw a need in all of us, the doctors and nurses and even non-clinical people, know what it feels like to be forgotten about, waiting for someone to come that never shows up. And I think we just collectively in this moment said, the weight of who you're waiting for is us. And we're going to be there for you. And we haven't stopped. And we have so much fun together. We're just truly committed, to serving the people, and we enjoy it, and it refuels us, refuels us.
I won't take up too much more of your time. I know you're a busy person.
I have nothing else to do but talk to you today. Oh, wait, I have something to show you. Did you see this? To tell people to vote?
Oh, that's right. That's right. Oh, look at that. That's fantastic. Okay.
Isn't that nice?
Yes, we still have time to vote, right? When does the voting end?
December 7th.
Oh, we got lots of time.
Yep. And you can vote every day. And it's for CNN Hero of the Year. And if we win, $100,000 comes to the consortium for us to continue our work in the community.
Well, so all that money will come back to Philadelphia. So
that's right.
It behooves us to vote often, vote early and vote often.
Yeah.
Well, I certainly will. All righty. Okay. Somebody's asking for the site to vote. That's CNN.
Yep. CNN Heroes. CNNheroes.com. You can vote every day. There's 10 votes. You can cast all 10 for me if you'd like,
Better.
And then on December 12th, there's like this whole live, awards thing in New York. And I'll be there, I believe, with the other 9 heroes. And so,
well, I'm going to say a prayer that you get that and that people vote. And by the way, while we're at it, congratulations on the cover of Philly Mag. You looked beautiful. You were killing it.
Thank you. I didn't even know that was out on Twitter before I even knew I was on the cover, right? And for the longest, I didn't post about it because I didn't believe it. I was like, until I touch that magazine, I can't, comment. But I had fun with that. And for this city that I love so much, it meant like everything to have that. And I'll always have that, I'll always have this moment and time and that cover that someday when I have grandkids, people will say, they'll be like, look at grandma on the cover. You know what I mean?
Right.
And that is, that's like a historic piece that I always have. So I appreciate those folks over there. Honestly, all of the journalists, and I mean, guys that write, the folks on the news have been so good to us in telling our story. And you didn't always agree with some of the things we did, but telling our story, and that's how we could even be considered for a national award, and that people are talking about us all across the United States and other parts of the world because you constantly stayed on top and wrote the story. So for everyone, thank you for doing that. People are like, who's your publicist? Oh my gosh, they're phenomenal. And I tell folks, I don't have a publicist. I never had a publicist. We just kept our heads down and we did the work. And publicity came, someone said, man, you couldn't buy that publicity. Like, how are you getting that? I'm like, we are working. We're here, and so
day in, day out, the heat,
day in,
the cold.
and right. And folks would want to interview
in the rain.
And I'd say, if I can, but you got to come to work. Even today, I'm in my office. They're outside, taking care of folks in the exam rooms. But if you come here to where I'm working, yes, I can accept the interview and so forth. And so thank you, really. Thank you. It's you guys and the people, because if they hadn't trusted us, there would be no story to tell, right?
And what a story. What a story to tell. And as we sign off, I have a comment from someone in the audience who says, Kerry Washington is going to play Dr. Ayla in the movie. Just putting it out there. I think that's an excellent idea. Okay, on that note, look at that face. Let's just leave it at that. We let you get back to work. Thank you so much for sharing your story with us. Thanks, everybody.
I appreciate you.
We appreciate you.
I've been telling everybody all day, unmute yourself. And so here I am. What I just said was, thank you so much for that terrific discussion. I cannot wait to read Dr. Stanford's book, whatever she calls it. It's going to be fabulous. And maybe we can talk about it next year at Telling Your Health Story. Denise, Dr. Stanford, thank you so much. That was such a great discussion and such a wonderful high note to end our day on. And thanks also to all of our terrific panelists and moderators, and to my wonderful behind the scenes colleagues, Angelica Irizarry and Renee Eiffel, who have made us all look as good and sound as good as we possibly could. Please remember that this entire day has been taped, so you can go back and rewatch or watch anything that you missed. It'll always be available for you at inquirer.com. Also, you'll be receiving a link to a survey, and I know we are all sick to bits of online surveys, but this one is really important, I promise you, because it's through these surveys that we put together next year's program. And this is the way that we can respond to your suggestions and your needs and continually improve what we're doing. Thanks again to our sponsors, Independence Blue Cross and the Robert Wood Johnson Foundation, and to the Lenfest Institute for Journalism, and of course, the leadership of the Philadelphia Inquirer. Health stories are told every day online at inquirer.com and in the pages of the Philadelphia Inquirer. So please check us out to see what your peers are writing, and please consider joining their ranks. We always welcome new storytellers to our pages. Thank you so much, and have a wonderful evening and a wonderful weekend.